Good morning, everyone. Today's date is January 26th, 2023. My name is Derek Bonner. I am a member of your AV support team for today's proceedings, and I'd formally like to welcome you to the 178th meeting of the Vaccines and Related Biological Products Advisory Committee. At this time, I'd like to hand our meeting over to our CBER Director, Dr. Peter Marks. Dr. Marks?
Thanks very much, and good day wherever you may be tuning in from. I want to thank you very much for joining us for this 178th meeting of the Vaccines and Related Biologics Products Advisory Committee meeting. I just want to let you know as we get started that due to unforeseen circumstances, Dr. Arnold Monto will be unavailable to chair today's meeting. However, we are lucky enough to be able to have Dr. Stanley Perlman stand in as the chair of today's meeting. Dr. Perlman is professor of microbiology and immunology, professor of pediatrics, and holds a distinguished chair at the University of Iowa, and his work focuses on coronaviruses. So I'll now turn the meeting over to Dr. Perlman.
Thank you, Dr. Marks. I want to welcome everybody to the meeting, the members, the participants, and the public who's listening in. This meeting is dealing with one important question and several important topics, and we have a very full agenda today. So our goal is to be both thorough and transparent in what we have to say. And with that, I'm going to turn this over to Suzanne Padar, who's our designated federal officer.
Thank you, Dr. Perlman. Good morning, everyone. This is Dr. Suzanne Padar, and it is my great honor to serve as the designated federal officer for today's 178th Vaccines and Related Biological Products Advisory Committee meeting. On behalf of the FDA and the Center for Biologics Evaluation and Research, CBER, and the committee, I'm happy to welcome everyone for today's virtual meeting. Today, the committee will meet in open session to discuss future vaccination regimens addressing COVID-19. Today's meeting and the topic were announced in the Federal Register notice that was published on December 19, 2022. At this time, I would like to introduce and acknowledge outstanding leadership of my division director, Dr. Prabhakara Treya, and the excellent work of my team whose contributions have been critical for preparing today's meeting, Ms. Karen Thomas, Ms. Joanne Lipkind, and Ms. Lisa Johnson. I also would like to express our sincere appreciation to Mr. Derek Bonner in facilitating the meeting today. Also, our sincere gratitude goes to many CBER and FDA staff working very hard behind the scenes trying to ensure that today's virtual meeting will also be a successful one, like all the previous VRBPAC meetings. Please direct any press media questions for today's meeting to FDA's Office of the Media Affairs at fdaoma@fda.hhs.gov. The transcriptionists for today's meeting are Catherine Diaz and Deborah De La Croce from Translation Excellence. We will begin today's meeting by taking a formal roll call for the committee members and temporary non-voting members. When it is your turn, please turn on your video camera, unmute your phone, and then state your first and last name, institution, and areas of expertise. And when finished, you can turn your camera off so we can proceed to the next person. Please see the member roster slides in which we'll begin with the chair, Dr. Stanley Perlman. Dr. Perlman?
Yes, hi, I am Dr. Stanley Perlman. I'm a professor of microbiology and immunology and pediatrics at the University of Iowa, and my expertise is in coronaviruses.
Great, thank you. Next is Dr. Paula Annunziato, non-voting member, our industry representative.
Good morning, I'm Paula Annunziato. I lead vaccines clinical development at Merck. And as you just said, I am the non-voting industry representative for today.
Thank you, Paula. Dr. Adam Berger. Dr. Adam Berger, yes.
Sorry, everything was really slow to uncheck for me.
No worries.
Video. Adam Berger, I'm the Director of Clinical and Healthcare Research Policy at the National Institutes of Health. I oversee all of our clinical research and clinical trial policies. Thanks.
Great, thank you. Dr. Henry Bernstein. Hank?
All right. There we go. Good morning, everyone. My name is Hank Bernstein. I'm a professor of pediatrics at the Zucker School of Medicine at Hofstra in Northwell. My areas of expertise include pediatrics and vaccines. Thank you.
Thank you, Dr. Bernstein. Dr. Archana Chatterjee.
Excuse me. Good morning, everyone. My name is Archana Chatterjee. I have the honor and privilege to serve as Dean of Chicago Medical School and Vice President for Medical Affairs at Rosalind Franklin University in North Chicago. My areas of expertise are in pediatrics and vaccines. I am trained as a pediatric infectious diseases specialist.
Great. Thank you, Archana. Captain Amanda Cohn.
Good morning, everyone. My name is Dr. Amanda Cohn. I am a medical epidemiologist at the Centers for Disease Control and Prevention, and my expertise is in pediatrics and vaccines.
Thank you, Amanda. Dr. Haley Gans.
Good morning, everybody. It's great to be here. I am a professor of pediatrics at Stanford University, and my main and the director of our pediatric infectious disease program for immunocompromised hosts. My main area of focus for my research is on vaccine immunology. Thank you.
Thank you, Haley. Captain David Kim.
Well, good morning, everyone. This is David Kim with the National Vaccine Program in the Office of Infectious Disease and HIV/AIDS Policy in the Office of the Assistant Secretary for Health. And I'm trained in internal medicine and with a particular interest in vaccine policy.
Fantastic. Thank you. Dr. Paul Offit.
Yes, good morning. My name is Paul Offit. I am an attending physician in the Division of Infectious Diseases at the Children's Hospital of Philadelphia and a professor of pediatrics at the Perelman School of Medicine at the University of Pennsylvania. And my expertise is in the area of vaccines, specifically mucosal vaccines. Thank you.
Thank you. Dr. Stephen Pergam.
Thanks, Susan. I'm Steve Pergam. I'm a professor in the Vaccine and Infectious Disease Division at the Fred Hutch Cancer Center. And my primary focus is on immunosuppressed patients and infections in that population.
Thank you. Dr. Eric Rubin.
Good morning. I'm Eric Rubin. I'm an infectious disease physician and researcher at Harvard, the Brigham and Women's Hospital, and New England Journal of Medicine.
Great. Thank you so much, everybody. Next, we will do a roll call of our temporary voting members. Dr. Bruce Gillen is not here with us right now. He will join us shortly.
I made it.
Oh, you are in, Dr.
I did made it. Thanks.
Oh, you made it on time. Perfect. Thank you so much for making it on time.
Thanks. So
from another continent.
It'll be a long day or a long night, but maybe for all of us. I'm Dr. Bruce Gillen. I'm currently a Senior Vice President at the Rockefeller Foundation. My training is in adult internal medicine and infectious diseases, and I've spent half a career in vaccine policy. Thanks.
Thank you, Dr. Gillen. Dr. Randy Hawkins, our alternate consumer representative. Dr. Hawkins.
Good morning. Randy Hawkins, Pulmonary and Critical Care Medicine and the acting consumer representative. I'm in private practice, pulmonary internal medicine, and on the faculty at Charles University of Medicine and Science.
Great. Thank you so much. Dr. James Hildreth.
Good morning. I'm Dr. James Hildreth. I'm the president and CEO of Meharry Medical College and professor of internal medicine. I'm an immunologist, and I study the interactions between viruses and their hosts and how they cause disease. Thank you.
Great. Thank you so much. Dr. Jeanette Lee.
Yes, good morning. My name is Jeanette Lee. I'm a professor of biostatistics and a member of the Winthrop P. Rockefeller Cancer Institute at the University of Arkansas for Medical Sciences, and my area of expertise is design and analysis of clinical trials. Thank you.
Thank you, Jeanette. Next is Dr. Ofer Levy.
Hello, good morning. Can you hear me, Susan? Oh, yeah.
Yes.
My name is Ofer Levy. I'm an attending physician in infectious diseases at Boston Children's Hospital and a professor of pediatrics at Harvard Medical School. I direct the Precision Vaccines Program, which is a multidisciplinary program to discover and develop vaccines tailored to vulnerable populations such as infants, immunocompromised hosts, those with comorbidities, and older adults. Thank you.
Thank you, Dr. Levy. Dr. Pamela McInnes.
Morning, my name is Pamela McInnes. I am a retired Deputy Director of the National Center for Advancing Translational Sciences at the National Institutes of Health. Thank you.
Thanks very much, Pamela. Dr. Cody Meissner.
Thank you, Dr. Padar. Good morning to everyone who was listening. My name is Cody Meissner. I'm a professor of pediatrics in medicine at the Geisel School of Medicine and Dartmouth Hitchcock Medical Center. I am also a vaccine subject matter expert at Barter within the Department of Health and Human Services. I appreciate the opportunity to participate in today's meeting. Thank you.
Thank you, Dr. Meissner. Next is Dr. Michael Nelson.
Thank you. Good morning. I'm Michael Nelson, allergist, immunologist at the University of Virginia, where I serve as chief of the Asthma, Allergy, and Immunology Division, as well as president of the American Board of Allergy Immunology. My expertise is in vaccine adverse events and allergic and immunologic diseases. So thank you.
Thank you so much, Dr. Nelson. Next is Dr. Art Weingold.
Good morning. I'm Art Reingold. I'm a faculty member at the School of Public Health at the University of California, Berkeley, with an interest in infectious diseases, particularly vaccine-preventable diseases. Thank you.
Great, thank you. Next is Dr. Mark Sawyer.
Good morning. I'm Mark Sawyer. I'm a professor of pediatric infectious disease at the University of California, San Diego. And my area of expertise are the public health aspects of vaccines. Thanks very much.
Thank you. And last but not least, Dr. Melinda Wharton.
Good morning. I'm an adult infectious disease physician who works in CDC's immunization program, and I work in vaccine program and policy. Thank you.
Thank you. Great. Thanks, everyone. We have a total of 22 participants, 21 voting and 1 non-voting member. So now I'll proceed with reading the FDA Conflict of Interest Disclosure Statement for the public record. The Food and Drug Administration, FDA, is convening virtually today, January 26, 2023, the 178th meeting of the Vaccines and Related Biological Products Advisory Committee, VRBPAC, under the authority of the Federal Advisory Committee Act, FACA, of 1972. Dr. Stanley Perlman is serving as the acting voting chair for today's meeting. Today, on January 26, 2023, the committee will meet in open session to discuss future vaccination regimens addressing COVID-19. This topic is determined to be a particular matter involving specific parties, PMISP. With the exception of industry representative member, all standing and temporary voting members of the VRBPAC are appointed special government employees, SGEs, or regular government employees, RGEs, from other agencies and are subject to federal conflict of interest laws and regulations. The following information on the status of this committee's compliance with federal ethics and conflict of interest laws, including but not limited to 18 U.S.C. Section 208, is being provided to participants in today's meeting and to the public. Related to the discussions at this meeting, all members, RGE and SGE consultants of this committee have been screened for potential financial conflict of interest of their own, as well as those imputed to them, including those of their spouse or minor children, and for the purposes of the 18 U.S. Code 208, their employers. Their interests may include investments, consulting, expert witness testimony, contracts and grants, cooperative research and development agreements, teaching, speaking, writing, patents and royalties, and primary employments. These may include interests that are current or under negotiation. FDA has determined that all members of this advisory committee, both regular and temporary members, are in compliance with federal ethics and conflict of interest laws. Under 18 U.S.C. Section 208, Congress has authorized FDA to grant waivers to special government employees and regular government employees who have financial conflicts of interest when it is determined that the agency's need for a special government employee's services outweighs the potential for a conflict of interest created by the financial interest involved, or when the interest of a regular government employee is not so substantial as to be deemed likely to affect the integrity of the services which the government may expect from the employee. Based on today's agenda and all financial interests reported by committee members and consultants, there have been one conflict of interest waiver issued under 18 U.S. Code 208 in connection with this meeting. We have the following consultants serving as temporary voting members: Dr. Bruce Gillen, Dr. Randy Hawkins, Dr. James Hildreth, Dr. Jeanette Lee, Dr. Ofer Levy, Dr. Pamela McGinnis, Dr. Cody Meissner, Dr. Michael Nelson, Dr. Art Reingold, Dr. Mark Sawyer, and Dr. Melinda Wharton. Among these consultants, Dr. James Hildreth, a special government employee, has been issued a waiver for his participation in today's meeting. The waiver was posted on the FDA website for public disclosure. Dr. Pamela Annunziato of Merck will serve as the industry representative for today's meeting. Industry representatives are not appointed as a special government employee and serve as non-voting members of the committee. Industry representatives act on behalf of all regulated industry and bring general industry perspective to the committee. Dr. Randy Hawkins is serving as the alternate consumer representative for this committee. Consumer representatives are appointed as special government employees and are screened and cleared prior to their participation in the meeting. They are voting members of the committee. We have a large number of federal and non-federal speakers, as well as some guest speakers today making various presentations on timely and relevant topics. The following speakers, guest speakers, and responders for this meeting have been screened for their conflicts of interest and cleared to participate as speakers for today's meeting. They are Dr. John Beigel, Associate Director for Clinical Research, Division of Microbiology and Infectious Diseases, National Institute of Allergy and Infectious Diseases, National Institute of Health, NIH, Bethesda, Maryland. Dr. Ritaparna Das, Vice President, Clinical Development, COVID-19 Vaccines, Moderna Incorporated, Cambridge, Massachusetts. Dr. Flip Dubovsky, Executive Vice President and Novavax Chief Medical Officer, Novavax, Gaithersburg, Maryland. Dr. Darren Edwards, Senior Director of Immunology, Infectious Disease Group, Moderna Incorporated, Cambridge, Massachusetts. Dr. Jefferson Jones, Commander, U.S. Public Health Service Medical Epidemiologist, National Center for Immunization and Respiratory Diseases, Center for Disease Control, CDC, Atlanta, Georgia. Dr. Nicola Klein, Director, Kaiser Permanente Vaccine Study Center, Professor, Department of Health System Science, Kaiser Permanente Bernard J. Tyson School of Medicine, Oakland, California. Dr. Ruth Link-Ellis, Lieutenant Commander, U.S. Public Health Service, Epidemiologist, Division of Viral Diseases, National Center for Immunization and Respiratory Diseases, Center for Disease Control, CDC, Atlanta, Georgia. Antonella Lozito, PharmD, Executive Director, Regulatory Affairs, Infectious Disease, Moderna Incorporated, Cambridge, Massachusetts. Dr. Heather Scobie, Surveillance and Analytics Team Lead, Acting, National Center for Immunization and Respiratory Diseases, CDC, Atlanta, Georgia. Dr. Tom Shimabukuro, Deputy Director, H1N1 Vaccine Force, Immunization Safety Office, CDC, Atlanta, Georgia. Dr. Kenna Swanson, Vice President, Viral Vaccines, Vaccine Research and Development, Pfizer Incorporated, New York, New York. Disclosure of conflicts of interest for speakers, guest speakers, and responders follows applicable federal laws, regulations, and FDA guidance. FDA encourages all meeting participants, including open public hearing speakers, to advise the committee of any financial relationships that they may have with any affected firms, its products, and if known, its direct competitors. We would like to remind standing and temporary members that if the discussions involve any other products or firms not already on the agenda for which an FDA participant has a personal or imputed financial interest, the participants need to inform the DFO and exclude themselves from the discussion, and their exclusion will be noted for the record. This concludes my reading of the conflicts of interest statement for the public record. At this time, I would like to hand over the meeting to our acting chair, Dr. Perlman. Thank you, Dr. Perlman.
Thank you, Dr. Paydar. And so now I will turn the meeting over to Dr. Peter Marks, who's the director for the Centers for Biological Evaluations and Research, for his introductory comments.
Thanks very much, Dr. Perlman. Before spending a few minutes introducing today's topic, I want to first take a few moments in remembrance of Dr. Oveta Fuller. She was a temporary voting member of the committee during the entire course of the coronavirus outbreak through its last meeting. And sadly, she died on November 18th, 2022. Dr. Fuller was a distinguished virologist at the University of Michigan School of Medicine, who focused her work on herpes virus entry and pathogenesis and translational research for HIV and AIDS elimination. She was dedicated to global public health and to health equity interventions to reduce infections and chronic diseases. We'll sincerely miss her contributions to the committee, and our thoughts are with her friends and family. Next, I'd like to introduce Dr. David Kaslow to people. He started at FDA this past October as the director of our Office of Vaccine Research and Review. Dr. Kaslow comes to CBER from PATH, where he served as the chief scientific officer for essential medicines and the head of PATH Center for Vaccine Innovation and Access. He previously served as the vice president of vaccines and infectious disease at Merck Research Laboratories, where he also served in advisory positions with MVI and the Bill and Melinda Gates Foundation. And prior to these positions, he founded the Malaria Vaccine Development Unit at NIH. And since coming to the agency, his scientific expertise and leadership have already distinguished him. And he will transition to running the vaccine and related biologics products advisory committee meetings in the future for the FDA side. And finally, I just want to take a few minutes to introduce today's topic of future vaccination regimens addressing COVID-19. It's simply a fact that the authorized and approved COVID-19 vaccines have helped to significantly reduce the morbidity and mortality from SARS coronavirus 2. That said, these vaccines were developed in record time during a period which we were and which we continue to be learning more about SARS coronavirus 2, not just about the virus, but also how it causes disease, and especially how rapidly it can evolve. Because of its rapid evolution, we've needed to adjust our approach over time, and we're now in a reasonable place to reflect on the development of the COVID-19 vaccines to date to see if we can simplify the approach to vaccination in order to facilitate the process of optimally vaccinating and protecting the entire population moving forward. And so that's under discussion today. So with that, I will turn this back over to the chair.
Thank you, Dr. Marks. Now I'd like to introduce Dr. Kaslow, who's already been mentioned. He's the director of the Office of Vaccines Research and Review at the Center for Biologicals Evaluation and Research, and I would ask him to have any introductory comments.
Thank you, Dr. Perlman, and thank you, Dr. Marks, for the very, very kind introduction. It is an honor to join this 178th meeting of VRPAC for the first time as director of OVRR. And as Dr. Marks noted, this is a consequential meeting to determine if we've reached a point in the pandemic that allows for simplifying the use of current COVID-19 vaccines, and if it is the moment to implement a more routine approach to periodically updating the strain composition of these vaccines. To frame today's discussion, I'd like to start by reviewing the current state of these two topics and ideally where we would like to be going in the future. Next slide, please. Currently, as Dr. Marks noted, there's over a dozen different COVID-19 vaccine presentations and several different immunization schedules authorized or approved in the United States, leading to complexities in implementation, use, and communication. In the future, ideally, the same COVID-19 vaccine strain composition would be used for both primary series and boosters. And in future periodic vaccine campaigns, a much simpler immunization schedule would be used, perhaps based simply on age, with a few risk-based adjustments, as will be proposed in a few slides. Next slide, please. As you'll hear in several presentations today, the virus continues to evolve rapidly, and revaccination with an updated vaccine has been shown to restore protective immunity. Going forward, FDA envisions an evidence-driven approach, similar in many ways to the process used for influenza vaccines, to monitor and update as needed the composition used in all COVID-19 vaccines, with the goal to induce or restore protective immunity through these periodic vaccination campaigns. Next slide, please. So with that framing in mind, FDA asked VRBPAC today to consider the following topics. Simplification from three perspectives. First, transitioning to the same vaccine strain composition for primary series and booster vaccination. Second, harmonizing the strain composition of all COVID-19 vaccines, be they mRNA or protein-based, for example. Third, simplifying the immunization schedule for future vaccination campaigns to administer one dose for most adults, adolescents, and older children, and for young children who were previously immunized, and potentially additional doses for high-risk older adults and persons with compromised immunity, and young children who have not been previously immunized. We'd also like VRBPAC to consider establishing a process for vaccine strain selection recommendations. Again, similar in many ways to that used for seasonal influenza vaccine, based on prevailing and predicted variants that would take place by June to allow for vaccine production by September. And importantly, if there is a need, convening an ad hoc VRBPAC meeting to address highly pathogenic escape variants. Next slide, please. The next three slides show at a very high level what is envisioned in the approach to periodic updating of vaccine strain composition. Shown on this slide is a proposed continuous and iterative three-step process in which integrated data are reviewed to determine the need for an updated composition recommendation, while in parallel and at risk, updated vaccine candidates are evaluated so that if and when a recommendation is made, manufacturers can submit to FDA a timely data package of their updated vaccines for review. In the third step, real-world evidence of the newly updated vaccine's effectiveness is collected and analyzed, which also starts the next three-step process. Next slide, please. Shown on this slide are the types of evidence that FDA would like to see generated and integrated as part of step 1 and 3. This includes continuous epidemiologic, clinical, and viral surveillance, continuous viral characterization at the gene, phenotype, and antigen level, and as mentioned on the last slide, vaccine effectiveness studies on each subsequent updated vaccine. An integration of these data would be used by VRBPAC to recommend a strain change. Next slide, please. Shown on this slide are the typical types of data that would be submitted and reviewed in step 2. Dr. Weir will review this in more detail in his presentation. Suffice it to say that FDA anticipates reviewing a comprehensive data package that may include manufacturing, non-clinical, and clinical data to authorize or approve an updated vaccine. Next slide, please. The final topic we're asking VRBPAC to discuss is an approach to simplifying the immunization schedule to be used in future periodic vaccination campaigns. An example of a potentially simplified immunization schedule was provided in the briefing document. Shown here for discussion is the underlying concept, which is Presumably at this point in the pandemic, most of the general US population have been sufficiently exposed to spike protein, either to infection, vaccination, or both, such that a single dose of a COVID-19 vaccine would induce or restore vaccine effectiveness. As you will see, some preliminary age-based data that suggest which age groups might fit into this category. As with the influenza immunization schedule, it is also possible that some risk-based adjustments to the immunization schedule may be necessary. It could be that more than one dose is needed. High-risk older adults, persons with compromised immunity, and young children who have not yet been completely immunized. At this time, those risk-based adjustments remain to be determined. Next slide. Before reviewing the voting questions and discussion topics, I'd like to just briefly review today's agenda. We will start with a series of informational presentations, first from CDC on the current epidemiology and an update of circulating variants. Also from CDC will be an update on bivalent vaccine effectiveness and safety, followed by FDA's update on bivalent vaccine effectiveness and safety, and then end the first session this morning with a presentation from NIH on improved generation COVID-19 vaccines. Next slide, please. Oh, next slide, please. Thank you. After a short break, we'll next hear from Moderna, Pfizer, and Novavax on their vaccines, and after lunch will be the open public hearing session, followed by FDA's presentations on the topics under consideration by VRBPAC. After a short break, there will be an additional question and answer session on the presentations, after which the committee will turn to the voting question and then the two discussion topics. Next slide, please. The voting question is directed at simplifying the use of current COVID-19 vaccines. FDA asked VRBPAC, does the committee recommend harmonizing the vaccine strain composition of primary series and booster doses used in the United States to a single composition? For example, the composition for all vaccines administered currently would be a bivalent vaccine with an original plus Omicron BA4, BA5 composition. Next slide, please. After voting on the question, VRBPAC is asked to discuss two topics. The first on periodic updates to COVID-19 vaccines for use in future vaccination campaigns. Please discuss and provide input on the consideration of periodic updates to COVID-19 vaccine strain composition, including to the currently authorized or approved vaccines to be available for use in the United States in the fall of 2023. Next slide, please. The second topic is on simplification of the immunization schedule. Please discuss and provide input on simplifying the immunization schedule to authorize or approve one dose for most adults, adolescents, and older children, and for young children who were previously immunized, and an additional dose for higher risk older adults, persons with compromised immunity, and young children who have not been previously immunized. And with that, I'll turn the floor back to our chair, Dr. Perlman.
Thank you, Dr. Kaslow. So we have 7 minutes now for questions from the committee. I see one hand is up. Dr. Meisner.
Thank you, Dr. Perlman, and thank you, Dr. Marks and Dr. Kaslow for your comments. I have one comment and one question. First, I wanted to thank the FDA and all the workers at your colleagues at CBER who put together the FDA briefing document. It's just an enormous amount of work, and thank you for bringing that into one package. The question I have for you, Dr. Kaslow, is it reasonable to make the decision in June in regard to composition of the vaccine for the following fall? That's obviously a much shorter time than the influenza vaccine, which is selected typically in February. Now it's a different vaccine platform with messenger RNA for the COVID-19 vaccines, but is that a reasonable goal? Over.
Thank you, Dr. Meisner, for the comments on the backgrounder and also for the question. I think that you're going to hear in the presentations today more detail on the process, the manufacturer's perspective on the feasibility of that as well. And so I think we should maybe come back to that question, particularly after Dr. Weir's discussion this afternoon or presentation this afternoon, where I think we'll go through a bit more of the detail that's involved in getting us there. But thank you for the question.
Thank you.
Dr. Levy.
Hi, Ofer Levy, Precision Vaccines Program, Boston Children's Hospital. Again, thanks to Dr. Kaslow, and I second Cody Meisner's comments on the FDA briefing documents, which were excellent. In the background just provided, a rationale was set for harmonizing, simplifying the approach, which makes good sense. And then an example was given, e.g., using the bivalent vaccines as the yearly booster or yearly vaccine. And I just wanted to know whether FDA is framing today's discussion to consider other options or emphasizing that option. I'm just trying to understand how this is being framed in terms of background. Thank you, Dr. Kaslow.
Thank you, Dr. Offer. Yes, no, indeed, this is being framed as a discussion topic, certainly not a voting topic, and the agency is quite interested in the input from the advisory committee on this topic.
Okay, thank you. Dr. Reingold.
Yeah, I'd certainly like to second the comments about the briefing document. Thank you to all the FDA staff. I just want a question that follows up a little bit on Dr. Meisner's question, which is, I think, beyond the question of how long would it take companies to produce a vaccine. The other question is when it would be optimal to administer it, and whether we're talking about trying to start administering a vaccine in September or October or November clearly might depend in part on how long we think the protection will last and what we think when most infections and illnesses would be occurring. So I think we need to at least think about when the optimal time for administering the vaccine is as well. Thank you.
Okay, thank you. And I think now we can move on to the presentations. There's no more questions at the moment. So if Dr. Scobie is ready, I will introduce her. She is the surveillance and analytical team lead and at the National Center for Immunization and Respiratory Diseases of the CDC. And she's going to give us an update on the current epidemiology of the COVID-19 pandemic and the SARS-CoV-2 variants.
Good morning. Can you hear me?
Yes.
Yes, we can. Okay, next slide. Next slide. This stacked bar graph shows recent U.S. trends in the national weighted estimates of variant proportions and nowcast projections of circulating SARS-CoV-2 lineages by week of specimen collection. The various Omicron sublineages have been over 99% predominant for many months now. For the week ending January 21st, XBB 1.5 in dark purple comprised 49.1% of sequences. BQ 1.1 in teal was 26.9%. BQ1 in dark green was 13.3%, and XBB in lavender was 3.3%. Several other BA2, BA5, and BA4 related lineages were 2% or less. Next slide. This map shows the relative proportions of the Omicron sublineages across the 10 Health and Human Services regions during the most recent week. XBB 1.5 in dark purple represented the majority of circulating lineages in regions 1, 2, and 3 on the East Coast, while BQ 1.1 in teal and BQ 1 in dark green represented the majority of circulating lineages in other U.S. regions. Next slide. This is a summary of the various circulating Omicron sublineages. 44% of circulating sublineages in the U.S. are related to BA4 or BA5 sublineages, which have the same spike protein that was included in the updated bivalent vaccine, and the remainder is attributed to BA2 related lineages. Although we have many different named lineages in circulation, most of these newer sublineages differ by only a few amino acids in the receptor binding domain from their parental sublineage. While XBB 1.5 in the bottom right has the highest number of mutations among this group, we also see evidence that these strains are co-evolving the same mutations, which in some cases, as shown in red, are known to impact monoclonal antibody treatments and likely contribute to partial immune escape more generally. Next slide. These are recent CDC data on the neutralizing activity of sera after receiving a monovalent booster in the top panel. The ancestral strain is shown in dark blue on the left, and different Omicron lineages are pictured in various colors to the right. The more recent variants are on the far left, EQ 1.1 in lavender, XBB in red, XBB.1 in pink, had the largest relative decreases in neutralization. The bottom panel shows the neutralizing activity of sera after receiving a bivalent booster and a total of 4 vaccine doses. Neutralization of all Omicron sublineages relative to the ancestral strain was notably improved after the bivalent booster, but XBB and XBB.1 still had the largest reductions in neutralization. A new publication from Ohio State University has shown equivalent neutralization of XBB 1.5 by bivalent booster sera relative to XBB and BQ 1.1. Next slide. Next slide. As of January 18th, there have been almost 101.9 million COVID cases reported in the U.S. and almost 1.1 million reported COVID-19 associated deaths. Next slide. This graph shows the weekly trends in reported numbers of COVID-19 cases overlaid with the weekly test percent positivity, which is a marker of transmission intensity. The trends aligned remarkably well in late 2020 through early 2022, but became uncoupled starting in May 2022, related to decreases in provider-based testing and increases in at-home testing. For this reason, cases reported to surveillance are underestimated. This month, after increases in November and December 2022, case counts and test percent positivity are starting to show decreasing trends, suggesting decreases in overall transmission. Next slide. These are the trends in age-specific rates of COVID-19 cases over time. More recently, case rates have been higher in older ages in purple and pink relative to younger ages in blue and yellow colors, compared with earlier in the pandemic. However, this may be related to differences in laboratory testing practices by age. Next slide. These are trends in the percent of emergency department visits attributed to patients diagnosed with COVID by age group from syndromic surveillance. Percentages have been decreasing in recent weeks, but were highest in children ages less than 2 years in yellow and older adults ages 75 plus years in the purple dotted line and 65 to 74 years in pink. Next slide. These are weekly trends in adult COVID-19 associated hospitalization rates by age group from COVIDnet. Higher hospitalization rates have always occurred in the 75 plus year age group in purple, followed by people ages 65 to 74 years in red, 50 to 64 years in pink, and 18 to 49 years in blue. On the right, you can see that since April, hospitalization rates have increased more in older age groups, especially for 75 plus years compared with younger adults. Next slide. These are COVID-19 associated hospitalization rates among children by age group. Pediatric hospitalization rates were relatively low during the first year and a half of the pandemic, but increased during the Omicron surge, especially for infants less than 6 months of age in red who were not eligible for vaccination, and children ages 6 to 23 months in orange who became eligible for vaccination in June 2022. COVID-19 hospitalization rates have remained highest in these two youngest age groups relative to children in older age groups. Next slide. These are weekly trends in the COVID-19 associated mortality rates reported from case surveillance by age group. The data show that higher mortality rates are consistently observed in older age groups, most notably on this graph among those aged 75 plus, 65 to 74, and 50 to 64 years, as shown in the purple and pink colors. Since April, we have observed decreased death rates in younger ages relative to older age groups, especially people ages 75 plus years. Next slide. This is a summary table of the cumulative incidence of cases and deaths by age group during the Omicron variant period of January 2nd, 2022 to January 18th, 2023. On the left, case incidence was relatively even across age groups with some variation, likely related in part to differences in at-home testing practices by age. On the right, death rates increased with increasing age among the adult age groups. Higher death rates were also observed for infants less than 1 year of age than in other pediatric age groups. However, this table does not separate out children younger than 6 months who are not eligible for vaccination. Next slide. This is a summary table from COVIDNet of cumulative incidence of hospitalizations by age group during the Omicron variant period of January 2nd, 2022 to January 14th, 2023. I note that there's a typo in the title there. Sorry about that. Here again, we see a pattern of higher hospitalization rates with increasing age and also among younger ages, most notably ages 65 to 74 and 75 plus years and ages less than 6 months, which were on the same order of magnitude. Children 6 to 23 months were also increased relative to older children. Next slide. Next slide. As of January 18th, over 229.5 million people in the U.S. have been vaccinated with a primary series, which is 73% of the population ages 5 years and older. Since first being authorized on September 1st, 2022, 50.6 million people have received an updated bivalent booster dose, which is 16% of the population ages 5 years or older. Next slide. These data show trends over time and by age group and the percentages of people who have received at least a primary series on the left and an updated bivalent booster dose on the right. In both figures, vaccination coverage is higher in older age groups, indicated in purple and pink colors. On the left, we can also see that children under age 12 years in the yellow colors who became eligible for vaccination more recently have the lowest coverage with the primary series. Coverage with the updated booster dose on the right is highest for the 65 plus age group in purple, followed by 50 to 64 years in pink, and younger adults in the blue colors. Next slide. This is a summary table of COVID-19 vaccination coverage by age group and dose opportunity. On the left, children ages less than 2 and 2 to 4 years became eligible for vaccination most recently, so they've had the fewest vaccination opportunities. They have the lowest coverage, and 90% or more of these groups are unvaccinated. On the right, adults aged 65 plus and 50 to 64 years who are at highest risk of severe disease have been targeted with the most vaccination opportunities, have the highest coverage, and only 5% of these groups are estimated to be unvaccinated. The other age groups in the middle reflect a gradation between these two extremes. Next slide. This is seroprevalence data reflecting categories of vaccine and infection history among U.S. adult blood donors overall on the left and by age group on the right for 2 surveys conducted in the first and second quarters of 2022. As expected, increasing proportions of vaccine-induced immunity only in blue and both vaccine and infection-induced immunity in green were observed in older age groups, while higher proportions of infection-induced immunity only in yellow were observed in younger adult age groups. During the second quarter survey, as shown in slightly darker shades, proportions of adults with both vaccine and infection-induced immunity increased across all age groups. I note that the most recent data presented here are for June 2022. Next slide. This is pediatric seroprevalence data from a national survey of commercial laboratory specimens by age group from March to December 2022, including new unpublished data. On the left is infection-induced seroprevalence, which was noticeably lower for children ages 6 to 11 months in light blue and children ages 12 to 23 months in green than in older age groups. On the right is combined seroprevalence for infection and vaccine-induced immunity, which was higher overall. However, combined seroprevalence was still lower for infants ages 6 to 11 months and children ages 12 to 23 months. Next slide. Next slide. This graph shows age-adjusted rates of COVID-19 associated hospitalizations by vaccination status and receipt of a booster dose. Hospitalizations for COVID-19 have consistently been higher among unvaccinated than vaccinated people over time. In November, adults ages 18 years or older and vaccinated with a bivalent booster had 16 times lower risk of COVID-19 associated hospitalization compared to unvaccinated people, and 3 times lower risk of COVID-19 hospitalization compared to people vaccinated without people without a bivalent booster. Next slide. For cases diagnosed in November 2022, people ages 5 years and older with a bivalent booster had 13 times lower risk of dying from COVID-19 compared to unvaccinated people, and 2 times lower risk of dying from COVID-19 compared with vaccinated people without a bivalent booster. These data suggest that getting an updated COVID-19 bivalent booster can enhance protection that might have decreased over time related to immune escape of variants or waning immunity and time since receipt of the last monovalent dose. Next slide. Unvaccinated people are at much higher risk of severe COVID-19 illness than vaccinated people. Most vaccinated people who get severe COVID-19 illness have multiple risk factors, including older age and underlying medical conditions like immunosuppression, diabetes, and chronic kidney, lung, cardiovascular, or neurologic diseases. Antiviral drugs can help reduce the risk of severe illness in people at higher risk. Next slide. In summary, CDC continues to monitor emerging variants like the sublineages of Omicron, including their prevalence and impact on disease incidence, severity, and vaccine effectiveness over time. Variation has occurred in rates of severe illness related to community transmission and emerging variants. However, an increasing proportion of severe illness over time has occurred in older adults, especially ages 75 plus years, and infants and children less than 2 years. There has been an increase in both vaccine-derived and infection-acquired immunity for all age groups, but susceptibility in children less than 2 years remains. It's important to stay up to date with vaccination, including receipt of updated bivalent booster doses in eligible populations to protect against severe COVID-19 illness. Therapeutics and multiple prevention measures should be used to protect people at higher risk of severe COVID-19 illness, regardless of vaccination status. Next slide. I'd like to thank the following people and organizations. Thank you.
Thank you, Dr. Scobie, for a really clear and informative presentation. And we have 15 minutes for questions. And before we start, I just want to make one comment. I wonder if the using neutralizing antibodies as the sole correlate of protection, which is what we kind of do, may need to be upgraded or changed a bit, because it seems like people are still pretty well protected, even though the antibody titers are very low to the newest variants. So with that, I will take the first question, Dr. Gantz.
Thank you very much. Thank you for that wonderful presentation, Dr. Scobie. I had a couple of questions. You showed us the variant range over our geographic area in the US for one single time point. And I'm wondering if it would be more helpful, and maybe we're hearing this at some point, to look at the trends, because as we know, strain variability does start in one location and then often wander over through the geographic areas as there's a different rate of disease in these areas. And this is important just because we have to understand if there is a notion to change based on some evidence, are these geographic variation, which we actually see globally, going to change and catch up with anything that we would consider, or are they going to stay stagnant? I think the answer to that is the first one. And my second question, and then I'll mute myself, we have this notion that severe disease can be impacted by the medications that we currently have available, but we should be very mindful that many of these medications are not available for children. So we need to sort of talk about that and consider that. And my last comment was the same as Dr. Perlman. I think we need to get away from neutralizing antibody titer measures as a marker of efficacy. Thank you.
Thank you. So I think, one, in terms of the regional variation, those graphs can be viewed by, or charts with the maps can be viewed by week if you're interested in regional variation on the CDC's COVID data tracker. But early on, before Delta became the predominant circulating lineage, we did observe regional circulation of a few lineages that never kind of reached predominance in the United States. Example might be like Epsilon, which was circulating on the West Coast. But since then, what we've observed is that if a variant has some sort of advantage, that it's generally taken over and swept across the country, no matter where it's first detected. And I think there's reasonable suspicion that that will probably occur with XBB 1.5 as well. So it's more or less just a matter of time, but I guess time will tell. We're in, of course, a new era with variants, with this so-called variant soup. We don't have a great term for it, but it's a collection of BA5, BA4, and BA2 related lineages. And as I noted, they often just differ by 1 or 2 amino acids from each other, which has been one reason where we haven't for a while had a clear kind of winner in terms of selective advantage. But it's seeming like with XBB 1.5, we're at that place now.
Okay, thank you. Dr. Hawkins?
Thank you very much, Dr. Scobie. I apologize if you answered this question. My question surrounds home testing and the impact on variant composition data. You advised us that COVID-19 infections are underestimated because of things like home testing. So how are home test results incorporated into this composition data? Variant data, that is.
So home test results are definitely not incorporated into genomic surveillance at this point. There's no framework for testing those home test specimens for sequencing. There are efforts to there are efforts like Make My Test Count, which is an effort, a government effort where you can report your home test results, and there's a website, and I believe you can see the results through that website. And CDC is working to make those data available publicly. I know that's either imminent or has already posted. So, but that's a separate issue in terms of making those data available as part of surveillance and validating whether they work as a surveillance measure that we can follow over time. But you're right in that in pointing out that framework isn't included in terms of what we test currently for genomic sequencing, which is limited to swabs.
And we think that this is not a significant factor.
Well, if you're worried, I mean, people who do home tests in general are not, they're either before the point of care seeking, or they have less severe cases, or they're doing asymptomatic screening for whatever reason because of contact. So if we were worried about catching all of those people and what's circulating among those more mild cases, I would say we have a problem. But I guess I don't think that that's a problem. That we're only focused on swabs, which are generally for people either seeking care because of more severe illness, or because they need to confirm that the test they ran at home is correct. So I don't think that it's a problem that we're not catching them in genomic surveillance.
Thank you.
Thank you. Dr. Gellin?
Yeah, thanks. Thanks a lot, Heather, for all of that. My question is derived really a bit from Dr. Perlman and Dr. Reingold's question about the timing and really duration of protection. What assumption are we using for how long after vaccination people are protected? Because that obviously will have implications for when we think they need to get more protection. Thanks.
And do you mean protected against infection or protected against severe illness? I think that there are differences there, and we need to be clear. Yeah.
Okay, then maybe you should put both on the table.
Okay. I mean, Dr. Linkellis is going to speak next and is going to show data that speaks to this. But I think in general, we're saying that the vaccines, protect for, protect pretty well for up to 3 months against infection, and much longer for severe infection. And that Dr. Linkellis should be able to speak to that better.
Dr. Meisner?
Thank you, Dr. Perlman, and thank you, Dr. Scobie, for a very thoughtful and thorough presentation. I would like to ask a question that I think we've discussed once before. I live in the state of Massachusetts, and the Massachusetts Department of Health reports every Thursday on the number of patients who are hospitalized with a positive assay and who are hospitalized because of COVID symptoms. And last January 17th, they reported there were 1,060 patients in Massachusetts hospitalized with a positive assay, but only 349 or 33% were hospitalized because of COVID symptoms. I think that's becoming increasingly important as we move into an era where these variants are clearly more infectious and cause more asymptomatic disease. And if we're going to introduce vaccines that have a novel composition or have altered schedules for administration, it would be very helpful to know not who's hospitalized with an assay, because that doesn't tell us a great deal. What we want to know is who is hospitalized because of symptoms due to COVID-19. And is it possible for the CDC to generate that data? Because there's no reason that Massachusetts, it seems to me, would be any different than any other state. So it suggests that your rates are 3 times higher than the actual rates. Over.
So the COVID-19 system, which is a hospital-based system, they've published papers that have shown, like you're saying, that people using an algorithm that looks at diagnoses and divides people out based on just likely scenarios. Are you there for obstetric care? Are you there for an accident? Things like that. They're able to provide a percentage of cases that they think are there not because of COVID, but just with COVID. And they have shown that has increased over time. So they usually provide that breakout in their publications. It's not broken out in the surveillance data that's reported online, but they do use a reasonable case definition, which is essentially that people who've tested positive in a reasonable amount of time before admission or within several days after admission are basically called a COVID-associated case. And those are the data that I presented to you today. So I think it's a reasonable thing to raise, but the trends that we're seeing are real, and that the cases are older over time, and generally have more underlying conditions, and so those publications exist and address your concerns, I believe.
Good. I agree with you that the trends are probably accurate. My concern relates to the absolute numbers. And because Massachusetts, if a patient is not getting dexamethasone or is not being treated for COVID disease, then it's unlikely that patient is hospitalized. So if the CDC incorporates those into their rates, I think that would be very helpful. Thank you.
Dr. McGinnis.
Thank you, Dr. Scobie. My question is going back to your earlier data on let me put my video on. Yeah, back to 101.9 million cases at this stage. And so I just wanted a little clarification, Pete. So I wasn't clear to me, it went quickly, about what the case ascertainment was. So this is detected by measurement. Is that correct? It's not an assumption.
These are cases reported to CDC. I believe you're referring to that slide that just showed.
It was an early slide, yeah. So if you, I know you don't like to speculate, you like to look at the data, but if these are measured cases, if this case ascertainment is by measurement and a positive result, what do you speculate the non-symptomatics are that have not appeared for medical care? I'm trying to get a sense of what percentage of the population might have been exposed to COVID, because it affects our discussion around hybrid immunity.
Yeah, well, I did present, to speak to your point, I did present the seroprevalence data, which is the most reasonable assessment that we have about people who've been exposed to infection. So those data address that and show that at this point, the vast majority of the U.S. population has either been exposed to infection or vaccinated or both. So those seroprevalence data were presented, and we could revisit that if you'd like.
So when you say vast majority, sorry, what do you mean?
We can go to that slide, but it's over 90.
Sorry, it went very quickly.
If Jefferson Jones is on the line from CDC, Dr. Jones, he may want to intervene and speak to the seroprevalence data.
Thank you.
Hi, thank you. So on slide 21 was presented, although the data are slightly old at this time, in Q2 of 2022, there had been 22% of adults that had infection-only induced immunity and 37% with hybrid immunity. So roughly 60% that had been infected, as evidenced by nucleocapsid antibody positivity. And that likely has continued to increase, although the numbers do differ quite a bit by age. And please let me know if you have any specific questions. So if you're looking at just the total numbers that have been infected,
yes,
then you would sum up the yellow and the green, which is an infection and hybrid immunity combined.
So 59%, it looks like, have been infected, and in Q2 of 2022, and a total of 94% have evidence of either having been infected or having been infected and vaccinated or vaccinated alone.
So the bottom line would be over 90% have either been infected or had vaccine and infection. Is that correct?
That's correct, and that's been correct since the end of 2021, really, as far as either infected or vaccinated.
So really no change in trend.
If you're just, there's big changes in trend in how many have hybrid immunity versus infection over time, as the number of people getting infected does accumulate, particularly, and we're only able to talk about first infections, as this data can't speak to reinfections.
Right.
But it is likely that cases are increasingly unable to detect the number of infections, both primary and reinfections. But the number of people that have any immunity from infection or vaccination has not greatly changed over the last year, as most people were either infected or vaccinated. But as you'll see in the next presentation, recent vaccination or recent infection won't be presented, but recency of infection or vaccination does have a substantial effect on protection against infection, and to a lesser extent, the degree of protection against severe disease as well.
Thank you very much.
Okay, thank you. I think we probably need to move on. I know there's other people who have questions, and there'll be time later to address those questions. But I think we need to move on to the next presentation by Dr. Link Gellis, who's the COVID-19 vaccine effectiveness program lead.
Good morning. Today I'll be presenting a summary of vaccine effectiveness data available from CDC studies and platforms, including vaccine effectiveness of both the original monovalent vaccines and updated bivalent vaccines. Next slide, please. I will first present estimates of vaccine effectiveness, or VE, of monovalent vaccines for symptomatic infection in young children. I'll then show early estimates of bivalent vaccine effectiveness for symptomatic infection due to XBB and its sublineages, as presented in yesterday's MMWR from CDC. Finally, I'll provide updates on VE of bivalent vaccine against severe disease in older adults. Next slide. Starting with VE for symptomatic infection in young children, ages 6 months to 5 years for Moderna and 6 months to 4 years for Pfizer-BioNTech. Next slide. So first, to orient everyone to the current recommendations, for younger children, 2 doses of Moderna vaccine are recommended 4 to 8 weeks apart for the primary series. August 1st was the earliest date that a child could have been considered to have a complete series. In other words, at least 2 weeks after completion of their second dose. If receiving the Pfizer-BioNTech vaccine, the primary series is 3 doses, with a first and second dose separated by 3 weeks and the second and third doses separated by 8 weeks. Since the series required an extra dose, the earliest date a child could have been considered to have a complete primary series was September 19th. For Pfizer, the third dose was changed to a bivalent dose on December 9th, but the analyses that I'll present today were restricted to monovalent doses only. Next slide. For background, I'm sharing the national coverage estimates from CDC's COVID data tracker for the primary series among children, shown in the red box in the middle of the slide. Note that this age group has the lowest coverage for either a single dose or a completed primary series at just under 10% for 1 dose and just over 5% for the complete primary series in children aged 2 to 4 years. Low coverage can cause VE estimates to fluctuate somewhat, as those vaccinated early may be meaningfully different from those that remain unvaccinated. And these estimates that I'll show in a few minutes should be considered preliminary. Next slide. The Increasing Community Access to Testing, or ICAT platform, includes community-based testing data from pharmacies and laboratory partners nationwide. It uses a test negative design with self-reported vaccine history at the time of the test registration. And for this analysis, only children whose caregivers reported symptoms and who were between the ages of 3 and 5 for the Moderna analysis and 3 and 4 for the Pfizer analysis were included. And this is because pharmacies generally only test children ages 3 and up. Children with immunocompromising conditions were excluded. Data are presented here for tests from July 4th, 2022 through January 17th, 2023, although the start date varies depending on the dose being analyzed. This was a period when the Omicron BA4 and BA5 sublineages predominated, though includes some time periods when XBB was also prominent. Next slide. So starting first with Moderna estimates for children ages 3 to 5 years, here we see preliminary estimates for VE against symptomatic infection for the monovalent Moderna vaccine series. On the top, we see a VE of 47% for 1 dose or a partial series during the interval between the first and second dose. On the bottom is VE for the complete 2-dose primary series of Moderna, with an overall VE of 57% during the 2 weeks to 3 months after the second dose. These estimates are fairly similar to older children and adults against symptomatic infection. Next slide. Moving on now to the Pfizer estimates. Here we see the same graphs, this time for Pfizer in children ages 3 to 4 years. On the top, for a 1-dose partial series, we see a VE of 12% with confidence intervals crossing the null. For 2 doses, which for Pfizer is also just a partial series, VE was 39% in the 2 weeks to 3 months after the second dose. And note that we did not have enough statistical power in this analysis to estimate VE for a 3-dose or complete series of Pfizer. Confidence intervals were too wide and did not meet precision thresholds for interpretation. Next slide. I'll now move on to present early estimates of VE for a bivalent booster dose against symptomatic infection with the XBB and its sublineages. Next slide. This is again using the national pharmacy testing data through the ICAT platform. I've highlighted the differences between the methods for this analysis and what was previously shown. Here we're looking at adults with COVID-like illness, so that's one or more COVID-like symptoms, tested at one laboratory partner that had S-gene target data available. Variant was determined using S-gene target reduction or failure as a proxy for infection with a BA5 related sublineage, and S-gene target presence was used as a proxy for likely XBB related sublineages, including XBB.1.5 that Dr. Scobie spoke of in her presentation. Tests in this analysis were completed between December 1st, 2022 and January 13th, 2023, and these results were published yesterday in CDC's Morbidity and Mortality Weekly Report. Next slide. And here we see those results. And again, these were just published yesterday and are available on CDC's website for those looking for more in-depth data. On the left, I show age group and vaccine dose pattern, including the reference group, which received 2, 3, or 4 monovalent doses and no bivalent dose. An overall group, that's those who are 2 or more weeks out from their bivalent booster dose, and then a subset of that group, those 0 to 1 month or 2 to 3 months since a bivalent booster dose. As mentioned on the previous slide, VE was calculated by S-gene target failure or likely BA5 related sublineages, shown here in blue, and S-gene target presence or likely XBB related sublineages, shown in pink. Generally, VE against symptomatic infection is similar for the two sublineages and across age groups. Confidence intervals are wider for the XBB analysis due to fewer cases, and we're continuing to monitor this as XBB.1.5 continues to increase nationally. Additionally, we've not seen substantial evidence of waning so far, but only had stable estimates through 3 months after receipt of the bivalent dose due to case counts and timing of vaccine authorization. And so we'll continue to monitor potential waning throughout the spring. Next slide. I'll now provide an update to an MMWR that was published by CDC in December, looking at the effectiveness of the bivalent booster vaccines against hospitalization in adults aged 65 years and up. The citation is shown here for those wanting more information on the original publication. Next slide. The IB Network is a multi-state VE platform that uses a prospective test negative design. For this analysis, participants were from 24 hospitals in 19 US states with hospitalizations between September 8th and December 29th, 2022. Note that this analysis includes 1 extra month of data beyond what was published in the MMWR in December. Participants are hospitalized with COVID-like illness and have a SARS-CoV-2 positive PCR or antigen test, and controls are negative for SARS-CoV-2 and influenza by real-time PCR. Next slide. And here we have the updated IB results with an extra month of data compared to the MMWR. On the left-hand side of the slide, you see the dosage pattern studied. I'll start first with the top section of the slide, which shows absolute VE. So that's VE comparing vaccinated people to unvaccinated people. The first estimate is for those who had a bivalent dose compared to those who had received no vaccine doses. And we see a VE for protection against hospitalization of 72%. Next, we show the VE of the two or more monovalent doses during the same time period and see that protection is 25% with a confidence interval crossing null. So these are individuals who received 2 or more monovalent doses but had not received a bivalent dose. Moving to the bottom of the slide, we show relative VE, that is incremental or additional effectiveness of a bivalent dose compared to people who had 2, 3, or 4 monovalent doses. This is shown comparing people who got the bivalent dose to those who received only monovalent doses and is split by time since last monovalent dose. We see protection here of between 61 and 65% with overlapping confidence intervals by time since last monovalent dose. Next slide. I do want to note that the point estimates have changed somewhat since the MMWR was published. The published data, which included hospitalizations through November 30th, are shown on the left-hand part of the slide, and the updated data that I showed on the last slide with hospitalizations through December 29th are shown on the right-hand side. You can see that although point estimates have dropped somewhat, they remain within the confidence intervals of the original estimates and do not change overall conclusions that the bivalent vaccines are continuing to provide substantial protection against hospitalization compared to individuals with 2, 3, or 4 doses of monovalent vaccine only. Next slide. And next slide. So to sum up, from CDC vaccine effectiveness platforms, we found that the complete 2-dose monovalent Moderna primary series provided moderate protection at 57% against symptomatic infection for children aged 3 to 5 years in national pharmacy testing data. The partial 2-dose monovalent Pfizer series provided modest protection at 39% in children 4 to 5 years between doses 2 and 3. And we did not have enough statistical power in this analysis to estimate VE for the complete 3-dose Pfizer primary series. For adults, early estimates of the bivalent booster doses show that the vaccines provided added protection compared to earlier monovalent doses against symptomatic infection due to XBB and its sublineages, and protection appeared similar to that for BA.5 and its sublineages. Finally, updates to the VE bivalent booster doses against hospitalization in adults confirm that the bivalent vaccines are providing protection against hospitalization compared to people who received 2, 3, or 4 doses of the monovalent vaccines and no bivalent dose. Those who had only received monovalent doses may have limited remaining protection. Next slide. This presentation represents the work of dozens of individuals and teams at CDC and at various study sites, and I want to thank each of them for the countless hours they've put into generating high-quality data and analyses for VRBPAC. Thank you, and I'll pass it on to the next presenter.
Thank you, Dr. Link-Ellis. So before we have questions, we're going to have the other side of the CDC presentation, namely safety issues, and these are going to be presented by Dr. Shimabukuro and Dr. Klein. Dr. Shimabukuro is the director of the Immunization Safety Office at the CDC, and Dr. Klein is the director of the Kaiser Permanente Vaccine Study Center.
Thank you. Could you advance to the next slide? So the objectives for today's presentation are to describe CDC's vaccine safety data link, rapid cycle analysis monitoring methods and assessment processes for statistical signals, to describe VSD RCA signal detection and signal assessment for ischemic stroke after the Pfizer bivalent booster dose, and to describe further evaluation and key next steps. Next slide. So bivalent boosters first became available in the US in September 2022. And as of January 11th, there's been 49.5 million bivalent boosters administered in people 5 years and older. That includes 21.3 million doses in people 65 and older. CDC and partners monitor the safety of vaccines using multiple complementary systems, and the safety data continue to support CDC recommendations that everyone eligible for a COVID-19 mRNA bivalent booster get vaccinated. Next slide. And I'll turn it over to my colleague, Dr. Klein.
Good morning. I'll be here to present the preliminary analyses of ischemic stroke after Pfizer bivalent booster doses. Next slide. So the vaccine safety data link, or VSD, you'll be hearing, for those of you who aren't familiar, was established in 1990. It's a collaborative project between the CDC and 9 integrated healthcare organizations, and includes electronic health record data on approximately 12.5 million individuals across all the sites. Next slide. So in this slide, this shows the number of COVID-19 bivalent booster doses and influenza vaccine doses administered over time amongst individuals over the age of 65 within the VSD. So focusing first on the red line, you can see those are the Pfizer bivalent boosters that you could see had is much higher than the line in blue, which represents the Moderna bivalent boosters. Now in green, you see the how many more influenza vaccine doses were administered within the vaccine safety data link within this population. What's also striking is that you can see that how many, the timing of the vaccine that occurred mostly in September, and by mid to late November, almost all the flu vaccine, as well as the bivalent boosters, had been administered within the vaccine safety data link. And that many more Pfizer bivalent doses were also administered than were Moderna, the VSD. Next slide. So just to take a minute to talk about the VSD rapid cycle analysis. So the strengths of ours is that we include our population, which is approximately 12.5 million people, which is equal to approximately 4% of the US population, across the VSD sites, which are geographically and racially and ethnically diverse. We use real near-time data with analyses updated weekly. And we have access to comprehensive medical records, including vaccinations and outcomes, which allow rapid chart reviews to obtain additional clinical information as needed. Now, these strengths have allowed us to use innovative methods for safety monitoring, including two that I'm just highlighting below, because that's what I'll be talking about today. And those are the vaccinated concurrent comparators. In this, we use recent vaccinees as comparators, because we expect them to be more similar to current vaccinees than unvaccinated individuals. And they offer the following advantages in that we can carefully adjust for potential biases associated with calendar time, which is very important, site and demographic factors. And analyses can begin sooner than alternative methods. Now, in addition, we also do supplemental analyses, which we conduct on a weekly basis. In these analyses, we use unvaccinated or unboosted as appropriate comparators, which we use to provide context for real time to they provide the context for our primary analyses. And then we believe that using vaccinated concurrent comparators with supplemental analyses offers substantial benefits when compared with either unvaccinated or historical comparators. Next slide. So for our rapid cycle analysis, or RCA, for bivalent boosters, we use pre-specified outcomes, which we assess during weekly sequential monitoring after COVID-19 bivalent booster. We looked at the risk of these outcomes 1 to 21 days following a bivalent vaccination compared with bivalent vaccinated individuals who were 22 to 42 days following the bivalent dose. And we use a signaling criteria for these analyses of a p-value less than 0.01, and that's a one-sided p-value. I'll talk a little bit more about this in a minute. Next slide. In terms of our analysis. So our analysis is a little bit complicated, so I'll go through it here with the figure. So this shows a vaccinee with outcome and a risk interval in the top panel. And that's represented by the heart. That's just a representation. It's not meant to be anything in specific. But for example, in the top panel, you can see that person was vaccinated on September 30th with a bivalent booster. On October 3rd, that person had an outcome, which meant that they were in the 1 to 21 day risk interval post-vaccination. So on October 3rd, we take our comparators, who are now in the comparison interval 22 to 42 days post-vaccination, because that person was vaccinated on September 3rd. And so now on October 3rd, that person was in the comparison interval. So on each calendar day, that October 3rd, that an outcome occurred in a vaccinee, be compared to the vaccinees in their risk interval with similar vaccinees in the comparison. And by similar for the comparators, we mean that on the same calendar day, they're in the same age group, and at the same sex, race, ethnicity, and at the same VSD site. So what this means is that every analysis that we do are adjusted for age, sex, race, VSD site, and importantly, calendar day. Next slide. So here's our case definition for our ischemic stroke definition that we've been using for the last 2 years or so for all of our RCA analyses. It's a complicated slide, but I will just focusing on the left-hand side. Those are the ICD-10 codes that we use to find incident cases, and those included transient ischemic attacks as well as cerebral ischemic attacks and related syndromes. On the right-hand side, I do want to point out that we also excluded in all cases of individual who had COVID-19 diagnosis or a COVID-19 positive test within the 30 days prior to their stroke. I do want to point out that there is an error on this slide. It's not the first COVID diagnosis or test, it's actually any COVID within the last 30 days. So that is an error on this slide. Next slide. So the bivalent, this is the bivalent RCA concurrent comparative analysis of ischemic strokes during the 1 to 21 day risk interval versus the 22 to 42 comparison interval. This represents the analysis I showed you the picture of. And what you can see here is that the analysis are two groups, which we had pre-specified these two different age groups. And in focusing on the 65 and over, you can see in red for the Pfizer. If you look at the adjusted rate ratio, 1.47, you can see the confidence intervals, which do not include one, but more importantly, what actually is our criteria is our one-sided p-value in red. You can see a 0.005, and that did meet the signaling criteria of less than 0.01. Whereas we did not see that. None of the other age groups or other booster Moderna versus have not signaled. Next slide. So just to take a minute of what happens when we have a signal, and I should point out that that was from January 8th, that data I just showed you, but that we had actually been signaling for several weeks at that point. So what happens when we have a RCA signal within VSD to assess it, whether it reflects a real effective vaccination on an outcome? And I will just mention that over the nearly 20 years that VSD has been doing RCA, we have had several signals. Actually, it's not that uncommon to have a signal in which we do an assessment to find out whether it's a real effect or not. In this case, the steps that we take are to do data quality assessments for error, anomalies, or missing later arriving data. We do analyses using different comparators than the primary concurrent. In this case, for example, unboosted, unvaccinated, or historical comparators to supplement the primary analyses. We do additional investigation to provide context, which include background rates. We do graphic displays of outcome incidents day by day after vaccination using temporal scan statistics to assess for parent clustering. And this examines a temporal clustering of an outcome event in subgroups defined by demographic site or a concomitant exposure such as flu vaccine. If the signal is driven by strong association by one subgroup or VSD site, further analysis by site or subgroup are done as appropriate. We do chart reviews to confirm case and collect additional data, such as the date of symptom onset. And then we consider epidemiological studies to further investigate surveillance findings. So next slide. So here are the preliminary analyses of the ischemic stroke after the bivalent booster amongst persons over the age of 65 years. Next slide. Next slide. This graph shows, the next slide, please, shows the ischemic stroke after Pfizer bivalent booster after age 65 counts and adjusted rate ratios. So what you see here are the number of cases and that in the 1 to 21 day risk interval from October 16th all the way through January 8th. Next slide. So now what you see here are the cases and the occurred within the comparison interval of 22 to 42 day interval, again through the same time frame. You can see the next slide. Now what you can see here is starting November 27th was the first time we saw a statistical signal on for this outcome for ischemic stroke. Now what you can see this has been persistent, although attenuating over the last 7 weeks. Next slide. And as of January 8th, where this data goes through, the rate ratio is 1.47. You can see the confidence intervals there, and that is the corresponds to the table I showed you in an earlier slide. A couple of things to point out here is that although the number of cases in the risk interval in the blue have been increasing, but mostly increasing at a smaller, there have been more incremental increases. The number of cases in the comparison interval have been increasing a little bit more over time, relatively speaking. And that is, as you can see here, the rate ratios have also been attenuating. And so now it's in the range of 1.5, or it's been for the last few weeks. Next slide. So what this slide shows is when we first started seeing the signal, we started looking at the ischemic strokes by day after bivalent boosters, and this is amongst persons age 65. So there's several things that are notable here on this graph. What you can see here is when we look for the temporal clustering, as I mentioned, we can see that there is a significant cluster at days 11 to 22 with the p-value, as you can see. But some things to point out is, for those of you familiar looking at these types of graphs, this is a cluster, but it's not quite so striking. You can see it, but it doesn't stand out as extremely striking, unlike some other signals which we have seen. For example, myocarditis, it's an extremely strong signal that you can see without doing statistics. This one perhaps is more subtle, although present, and it is statistically significant. But the other thing that's important that I want you to keep in mind as you think about this graph is that when you look at the comparison interval of 22 to 42 days, it looks lower than the other parts of the graph. And so the question now becomes, is this increased rate ratio, is it because there's a higher rate within the risk interval, or is there an unexpectedly lower rate during the comparison interval? And so I think perhaps it's a little bit of both, but we'll talk about that more as we go on. Next slide. So what we also did was we looked at some preliminary charts. Now, this is a small subset of our cases, just to be clear, amongst those who are over the age 65 only during days 11 to 21 post-Pfizer bivalent booster vaccination. These were started early on after we first started the signal, in early December, we started looking at these charts. And so we viewed 24 cases, and we found that 22 of the 24 were incident strokes or TIAs with a predictive value of 92%. So none had a history of stroke or TIAs. The median age of the cases was 77.5 years. Symptom onset date rarely shifted from the electronic date. 5 or 23% had a known history of SARS infection, but only 1 was within the last 6 months. 0 had any mention of recent exposure to SARS-CoV-2 in the chart notes, and 14 or 64% had flu vaccine co-administered on the same day, and nearly all of those were high-dose flu. So for the outcomes, 13 of the 22 were discharged home, 4 of 18% discharged home with home health, 2 of 22 or 9% discharged to a skilled nursing facility, and 3 died, or 14%. One of the deaths was in a 75 to 79-year-old male, approximately a month after the stroke, and death appeared likely to be related to the stroke. 1 stroke was in a 65 to 69-year-old female, which was noted after craniotomy, and although the relationship with the surgery was unclear, and the death was due to cardiac arrest 2.5 months later. And then the third individual had a stroke in a 70 to 74-year-old male during a hospitalization for metastatic cancer with subsequent death due to the cancer-related complications during that same hospitalization. Next slide. So we've also done some supplemental analyses, and in this one, we looked at the ischemic strokes during the 1 to 21 day interval. In this case, it's the same cases I showed you earlier in primary analysis, but now we're comparing them to unboosted concurrent comparators, but those individuals are eligible for a bivalent booster in that they've had prior monovalent doses, and their concurrent comparators, which they're also well adjusted for age, sex, race, site, and calendar day. So these are adjusted analysis, but when we look at these analysis, we can see that the adjusted rate ratio is 1.07 with a confidence interval which includes 1, and the p-value is not significant. So this is a little inconsistent with our findings from our signal primary analysis. So we're going back to the picture I showed you earlier with the graph where I mentioned about the comparator intervals. We've done these additional supplemental analysis. Next slide. And in this case, what we've done is a little complicated, but this shows this ischemic strokes during the 1 to 21 and 22 to 42 day interval, comparing the bivalent booster versus the unboosted comparators, again, eligible for bivalent boosters. So in this slide, you can see the highlighted in red are those cases that occurred in our comparison interval, the 22 to 42 day interval. And when we compare those, again, with the unboosted comparators, we can see a rate ratio which is significantly lower than 1 at 0.76, and you can see the p-value. So what this is suggestive that perhaps we are seeing a reduced rate of strokes in the comparison interval. Next slide. So we've done some additional post-signal analyses, and in this one, we've looked at concomitant high-dose or adjuvanted flu vaccines. Next slide. So in this post-signal analysis, they were looking at this ischemic stroke instance during the days 1 to 21 day compared with days 22 to 42 day among 65-year-olds with and without simultaneous influenza vaccine. So when you look at the top row, you can see that that analysis represents individuals who received both bivalent Pfizer and same day high-dose or adjuvanted flu vaccine. And you can see that there are 20 cases in the risk interval and 40 cases in the risk interval and 20 cases in the comparison interval for adjusted rate ratio of 2. Now, just a word, that adjusted rate ratio is not nearly as finely adjusted as our prior analysis. These analyses were only adjusted for age, but not calendar time and other factors. But you can see it's a significant rate ratio. However, when we look at the bivalent Pfizer without any same-day flu, just by itself, we see 60 versus 58 in the comparison interval for adjusted rate ratio, just 1.03 and not significant. So again, this is suggestive that those who received concomitant vaccine had a higher rate ratio. However, back to what we talked about earlier, the question is that 40 higher than we would expect, given the increased stroke, or is 20 less than we would expect in the comparison interval? So we've done some additional analysis in the next slide. So again, it's a little complicated. I'll try and walk you through this. This one, we looked at the expected cases after bivalent booster and high dose or adjuvanted flu vaccine based on ischemic stroke instance in unboosted people eligible for booster. So we took those individuals, which I showed you in the earlier slide, who we used as the unboosted comparators, and we assessed how many cases of stroke we would expect in a 3-week interval, which represents either a risk or comparison interval. We did it by age in an age-adjusted way, because the stroke matters so much by age. And when you see as a total, you can see that in that period, we would expect 34.5 cases in a 3-week period using them as a comparison. And what we observed, as I just showed you in the earlier slide, we saw 40 cases in the risk interval. However, we only saw 20 in the comparison interval. So the 40 is a little bit more than we would expect, but the 20 is less than we would expect. So again, these findings are also suggestive that there's a reduced rate of stroke in the comparison interval. Next slide. So here's a summary of the findings of ischemic stroke following bivalent Pfizer COVID-19 mRNA booster vaccine, again, in persons aged 65 older. So we have a statistical signals persistent for 7 weeks. I will say that in the data from just a couple days ago, it has attenuated substantially and actually has not signaled this past week for the first time. But the rate ratio had slowly attenuated from 1.92 to 1.47, but it's continued to meet signaling criteria until just a couple days ago. Additional signal investigation analysis, we found temporal clustering evaluation found a significant cluster 11 to 22 days after vaccination. Supplemental analyses using unboosted concurrent comparators show a rate ratio of 1.07. That's not statistically significant. Of a small subset of charts reviewed, most confirmed cases had co-administered high-dose or adjuvanted flu vaccine. Analyses evaluating concomitant high-dose or adjuvanted flu vaccine showed a rate ratio of 2 that was statistically significant. Our separate analysis, which are not shown here, did not detect an elevated rate ratio for stroke after vaccine alone. Those are separate data not shown. And then finally, can you go back one more? Supplemental analysis suggests comparison interval 22 to 42 day rates were lower than expected. Next slide. So there are some additional considerations to think about with these data. So there are small numbers of strokes and imprecise rate ratios, which limit some analyses. We had reduced follow-up time after Moderna boosters due to distribution delays. And concomitant flu analyses were limited by small numbers. It's difficult to interpret the temporal clustering during risk and comparison intervals. There's also possible unmeasured confounding. Results may have been influenced by confounders that vary over time. Importantly, do early adopters of bivalent booster vaccines have a greater risk of near-term cardiovascular events? However, the same trend has not been observed for acute myocardial infarctions, and it's difficult to, it's very challenging to assess the potential impacts of differential vaccine availability after the EUAs, with there being so much more Pfizer than Moderna being available. And then the possible roles of SARS-CoV-2 infection before the booster. So the background incidence of SARS-CoV-2 infection was rapidly changing during bivalent booster uptake. And just a word analysis that we did, which excluded cases with a COVID-19 diagnosis or positive test within the prior 30 days. So that was our case definition. However, asymptomatic infections and home antigen tests are not consistently documented in our EHR, which is not unique to VSD, but that is what's happened in the landscape of COVID. However, when we did chart reviews, we did not find recent SARS-CoV-2 infection exposure evidence. Next slide. I think I'll turn it back to Dr. Shimura-Bakuro.
Thanks, Dr. Klein. Next slide, please. So to sum up, we'll continue to monitor weekly and explore potential data-related explanations for the statistical signal in VSD. We'll consider expanding chart reviews to all VSD sites, and we'll consult with other surveillance systems to better understand the possible role of concomitant high-dose or adjuvanted flu vaccination with COVID-19 vaccination and the possible decreased rate of stroke in the 3 to 6 weeks following vaccination. Next slide. Just want to reinforce that CDC continues to recommend that everyone eligible for a COVID-19 mRNA bivalent booster or a flu vaccine get vaccinated, and CDC and FDA are engaged in epidemiologic analysis regarding co-administration of COVID-19 mRNA bivalent booster and flu vaccines. Next slide. Next slide. And next slide. Thank you. That concludes our presentation, and we'll be happy to take questions.
Okay. Thank you, Dr. Shimura-Bakuro and Dr. Klein, for very clear presentations. I think one comment before we take questions, I think, as you know, it'll be very important to convey these data in a way that the public can understand the issue of ischemic strokes. So with that, we have about maybe 6 or 7 minutes for questions. I see Dr. Gantz. Can you take it away?
Thank you so much. I really appreciated the deep review of how these VSD and these safety signals are looked at. And I appreciate this ischemic stroke. My main question is just, I realize that you're looking at this potentially because this is the signal that you found more recently, but I'm wondering, and especially for the general public, to discuss all of this, the other safety signals that are being monitored routinely and what we can expect. And this will be very relevant specifically when we, if we're going to determine that these are going to be reviewed annually or whenever the FDA meets, because it's important to note that other safety parameters are being looked at. And I think it's important to note which ones they are and that they get the same scrutiny. Thank you.
Could you please go to the very last slide of the presentation and the extras? Because I think that it'll just give you some context for our monitoring. Is it possible to pull up the safety presentation and just go to the last slide? Okay.
With AV support, our technician is pulling that up for you.
Okay, that slide actually shows the very last slide in the entire presentation. So these are the VSD rapid cycle analysis pre-specified surveillance outcomes and the settings in which we're monitoring them. And I'll just reinforce for the bivalent booster rapid cycle analysis, the only outcome we signaled for is ischemic stroke for the Pfizer vaccine in the 65 and older. But here's a listing of our surveillance outcomes. VSD.
And are there any considerations, just to follow that up, on the idea of, quote, long COVID? I'm looking at this list here, and obviously that's a group of symptoms, but how are we monitoring for that? Because there has been some, at least in the VAERS, some reporting.
So we are monitoring for those types of symptoms in VAERS. VAERS is basically a spontaneous reporting system, so anything can be reported in. That's a challenging outcome to monitor in VSD. I think it would probably be multiple sign and symptom codes. So I would say that there are certain outcomes which lend themselves well to monitoring in VSD rapid cycle analysis. Maybe Dr. Klein can explain why certain outcomes are appropriate for RCA, and then the problems with other outcomes which may have long-term insidious onset and multiple symptomatology and a little more not really well-defined acute outcomes. Dr. Klein, if you want to.
Certainly, but I think you've pretty much stated the type of outcomes that are really well suited for rapid cycle analysis, which we update data weekly. We need to have clear diagnosis and ones that we can identify readily, and the outcomes that work best are ones that occur relatively close proximity to vaccination, and not perhaps weeks to months, but just more like days to weeks. And then that also we have a reasonable confidence that the diagnosis represents the outcome, because these are all done electronically. This is surveillance. And so we want to, although as you can see here today, we do deep dives, we find signals. We don't want to be constantly investigating signals if we don't have reasonable confidence in our outcome to begin with. So something like long COVID, well, VSD could do a different type of study, but not a rapid cycle analysis, because it's just not well given its long insidious nature and its indistinct diagnosis.
Okay, thank you. I think we should go to the next question. Dr. Reingold.
Thank you. So I just want to ask a question, or maybe just point to something, which is that when we think about the risks and benefits of vaccination, if you think about influenza and influenza vaccination, my recollection is that studies show that people who have flu are at increased risk of stroke and heart attack for a protracted period of time after they recover. And so if the same were true for COVID-19, then I think you need to think about how much COVID you prevent and how much of perhaps the later strokes and heart attacks that might be associated with those COVID events, if there is an increased risk of stroke associated with vaccination. So to look at the overall benefits of vaccination, we need to take that kind of effect into account as well. Thank you.
Thanks, Dr. Reingold. And I think that fairly shortly there will be an opportunity to present these findings in the context of benefit risk assessment at an ACIP meeting.
Okay, thank you. I think we need to move on to the next presentation, and we can come back to the other questions later. So the next presentation is by Dr. Forshee from the FDA, who's going to talk about, give us an update on the original COVID-19 vaccine and COVID-19 vaccine bivalent effectiveness and safety. So Dr. Forshee is the Deputy Director of the Office of Biostatistics and Pharmacovigilance at the FDA.
Good morning, everyone, and thanks for the opportunity to speak here today. Again, I'll be giving an update on some of our safety and effective analyses for the COVID-19 vaccines. Next slide, please. So this is an outline of the presentation. I'm going to start by giving a brief overview of the CBER Active Surveillance Program, which we call the Biologics Effectiveness and Safety, or BEST initiative. Then I'll talk about our safety surveillance for the bivalent COVID-19 mRNA vaccines. I'll provide an update on a study we did of real-world effectiveness of the mRNA COVID-19 vaccine among nursing home residents over 65 years of age, and then a conclusion for the presentation. Next slide, please. This gives an overview of the data sources that we have available through our research partners in the BEST initiative. The point to make is that we have a wide variety of data sources available that includes claims, EHR, and linked EHR and claims data sets that cover hundreds of millions of patients across a wide time range. Next slide, please. For our current rapid cycle analysis or sequential analysis that I'll be discussing, we use the following data sources. We have data from the CMS Medicare system for ages 65 plus. This was approximately 36 million recipients that were included in that study. 3 of the data partners were included in our sequential analyses. One point to note here is that we have a lot more individuals in the 65 plus and 18 to 64 age ranges than we do in the pediatric population. Next slide, please. One of the concerns that all of us doing this sort of safety surveillance have had is that there has been some underreporting of the COVID-19 vaccinations. This was especially true early in the vaccine rollout when many of the vaccines were given at mass vaccination clinics, and those vaccinations were not always seen in the health claims databases. To help deal with that problem, we have worked very hard to establish agreements with many immunization information systems to supplement the information on COVID-19 vaccination status. Next slide, please. I want to briefly remind the committee and the audience of the different phases of vaccine active surveillance. We generally begin with descriptive monitoring to provide descriptive statistics of the vaccine doses and selected adverse events. What I'll be focusing on in this presentation is the signal detection phase. In this phase, we typically perform sequential testing so that we take repeated looks as vaccine doses accumulate. And the goal here is to identify potential safety risks early so that we can provide further investigation. It's important to note that at this stage, the signal detection methods do not prove any causal relationship. They only tell us where we may want to look more to better understand what we have found. The final stage, which we are not at yet in our study, is the signal evaluation stage, which uses more robust study designs to evaluate potential safety signals seen in the signal detection phase or raised from other sources. Next slide, please. Now I'm going to move to talk about the status of our bivalent COVID-19 mRNA vaccine safety surveillance. Next slide, please. So this summarizes the administered doses that we have observed by age group so far in our rapid cycle analysis. For the 65 plus population, and again, this is our Medicare population, we've observed more than 7.3 million bivalent COVID-19 vaccine administrations. The majority of those have been for the Pfizer-BioNTech vaccine, with more than 4.2 million doses for that. The numbers for the younger age groups are smaller, and we only have 210,000 bivalent vaccines observed so far in the youngest age group. Next slide, please. Just briefly, I wanted to discuss the study design that we're using here. Again, this is a rapid cycle analysis that cannot establish a causal association. We look at a number of age populations. The exposures that we're looking at are the 2 bivalent mRNA COVID-19 vaccines. We're using a method called max SPRT, that stands for sequential probability ratio test, and the comparator that we're using are historical rates. Next slide. This is a list of the outcomes that we are monitoring. They are similar to the outcomes that CDC monitors, and we've had numerous discussions about the adverse events that we're each monitoring. The closest analog to the ischemic stroke that was discussed in the previous presentation in our analysis is non-hemorrhagic stroke. The key difference between the two is that we did not include transient ischemic attacks, or TIA, in our definition of non-hemorrhagic stroke. Next slide. So this shows the signals that have been detected so far in our sequential analysis of the bivalent vaccines. Looking first at the Medicare population, ages 65 years and older, we have so far not detected any signals, including for non-hemorrhagic stroke. And I should note that non-hemorrhagic stroke has reached the predefined limit of the safety surveillance because of the number of outcomes that we have observed. In the adult population, the only signal that we have seen so far has been a signal for myocarditis, pericarditis for the Pfizer-BNT bivalent vaccine. This was in the 18 to 35-year-old population. This is something that was observed with the monovalent versions of the vaccine as well. Next slide. Several of our outcomes have already completed the surveillance period without a signal, and therefore they will not signal during this analysis. They include acute myocardial infarction, deep vein thrombosis, Bell's palsy, and common site thrombosis, thrombocytopenia. Those are for the Pfizer vaccine only. Non-hemorrhagic stroke has completed the surveillance period for both vaccines, and the surveillance period has ended for pulmonary embolism for the Pfizer vaccine. Next slide. This provides a little more detail on the rate ratios that we saw for the non-hemorrhagic stroke for the Pfizer bivalent. Again, we were comparing to 2019 historic rates. The key point that I want to note here is that the rates of non-hemorrhagic stroke that we have seen in our surveillance are below the levels that we see in our historical rate comparison. In the most recent observation period, the rate ratio was 0.76. And again, we've reached the maximum length of surveillance without a signal. Next slide. The issue of concomitant influenza vaccination, especially with high dose or adjuvanted vaccines, was highlighted during Dr. Klein's presentation. In our analysis, we've seen approximately 4.25 million doses of the Pfizer-BioNTech bivalent vaccine in individuals 65 years and older. Of those, 38% of the recipients who received a Pfizer bivalent COVID-19 booster also received a seasonal influenza vaccination on the same day, and the vast majority of these were either high-dose or adjuvanted vaccines. In addition, 78% received a seasonal influenza vaccination within plus or minus 42 days from the receipt of their COVID-19 bivalent booster. We're continuing to do more work to segment out the different influenza vaccines administered. And again, no signal at this time has been seen for hemorrhagic stroke, even though we have 38% that received a concomitant influenza vaccination. Next slide. So in summary, these are the results of a large-scale signal detection study of the two COVID-19 mRNA bivalent vaccines. It's been conducted in multiple databases. It is still ongoing for some age ranges and some outcomes. The only signal we have detected so far is for myocarditis, pericarditis following the Pfizer bivalent vaccine among adults 18 to 35 years old. For the adults 65 years and older, several adverse events have already completed the surveillance period because of the large number of doses and outcomes that we have seen. As I've mentioned before, these signal detection studies do not establish a causal relationship, and further evaluation of signals is required using more robust study designs. The surveillance is ongoing, and particularly in the younger age groups, and will be expanded to the youngest, less than 5-year-old recipients as we get sufficient exposure in that group. Next slide. Because of the results that have been presented from the CDC and BSD analyses, we have done further exploration as to into other data sets, looking for information on the potential safety risk of ischemic stroke. So far, the data that we have seen suggests the absence of a safety risk for the bivalent boosters in age 65 years and older. There have been no excess reports of stroke from VAERS. I've just reported on what we found in our CMS sequential analysis showing no increased risk in stroke. The Veterans Affairs database has also done a preliminary run that did not find an increase in stroke. We contacted a number of our international regulatory agencies, and various countries in Europe as well as Israel have indicated no increased risk of stroke in their surveillance systems. We also contacted Pfizer and they consulted their global safety database, and they did not see any increase or a signal for the for ischemic stroke in their systems. In any case, because of the information that we have seen, we at FDA have launched a formal epidemiological study. We're working on the protocol right now to study, in particular, the concomitant administration of high dose or adjuvanted influenza vaccines and the COVID-19 bivalent vaccine in order to prepare for potential vaccine co-administration in the 2023-2024 season. Next slide. Next, I'm going to discuss data that we have on real-world effectiveness of the mRNA COVID-19 vaccines among U.S. nursing home residents aged 65 years and older. This will be for the monovalent boosters because we have not accumulated sufficient data on the bivalent to estimate the real-world effectiveness yet. Next slide. Next slide. For background, we all know that the COVID-19 pandemic caused substantial morbidity and mortality, especially among older adults residing in nursing homes. Therefore, we designed a study specifically looking at nursing home residents to understand the effectiveness of the mRNA COVID-19 vaccines among this population and across time in order to support effective policymaking and vaccine development. Next slide. The observation period for the study was December 13th, 2020 through November 20th, 2021. The exposures looked at mRNA COVID-19 vaccination status. The population that we were looking at was the Medicare fee-for-service beneficiaries aged greater than or equal to 65 years residing in U.S. nursing homes. And the primary outcome was COVID-19 related deaths, COVID-19 hospitalizations, and combined COVID-19 hospitalization or death. Next slide. As was mentioned before, we are always concerned about potential underreporting of vaccination and the bias that might introduce. To minimize that in this study, we conducted a quantitative bias analysis during the protocol development stage to evaluate the impact of potential exposure misclassification. And we also used exclusion criteria, and we excluded beneficiaries who resided in a nursing home that reported less than 10% of residents were vaccinated on or before March 1st, 2021, or if a second or third dose was observed without the preceding dose. Next slide, please. These are the FDA final study populations. There were a total of approximately 348,000 nursing home residents 65 years or older. The majority of those, 61%, were in the 2-dose cohort and 21% were in the booster cohort. Next slide. This chart summarizes the adjusted vaccine effectiveness for COVID-19 associated death in the pre-Delta and Delta periods during periods of high circulation of COVID-19. So you can see that in the pre-Delta period where there was 0% Delta circulation, the two-dose vaccination was providing almost a 70% effectiveness against COVID-19 associated death. When we move forward to the period where Delta was the predominant circulating strain, those who had only received 2 doses had seen their effectiveness fall to 55.7%, whereas those who had received a booster saw their the vaccine effectiveness of 88.7%. Next slide, please. This slide is a similar slide looking at COVID-19 associated hospitalization. This is for all time periods. The statistical method we were using did not detect any interaction between vaccine effectiveness and the circulation, level of circulation. So we see a similar pattern here of 65.3% vaccine effectiveness for 2 doses in the pre-Delta period. During the Delta period, those with only 2 doses saw the vaccine effectiveness fall to 40.4%, whereas those who received a booster saw 76.8% vaccine effectiveness. Next slide, please. There are a couple of limitations to our study. In particular, it's impossible for us to disentangle the possible effect of the waning of immunity in the time since someone received their vaccinations from the change in the circulating strains with the rise of Delta during the time period that we were looking at. Both of these likely contributed to the observed decrease in effectiveness in the higher Delta periods. And also the study period does not extend far enough into the booster dose administration phase for us to make estimates for the vaccine effectiveness of the bivalent booster doses. Next slide. So concluding the presentation, the BEST initiative leverages its infrastructure and capacity to generate data for evidence-based regulatory decisions. We try to rapidly respond to emerging public health concerns. We use our resources to expand the scientific evidence database and to inform and promote public health. Next slide. This is a large team effort, and I'm presenting on behalf of the team. Next slide, please. I think that may be the end of the presentation. So thank you very much for your time and attention.
Thank you for a very good presentation. We have about 10 minutes for questions. So Dr. Chatterjee.
Yes, thank you very much, Dr. Perlman. Dr. Boshi, thank you for your presentation. I have 2 questions for you. The first one is with regard to the definition of ischemic versus hemorrhagic stroke, because it seemed like for the VSD analysis, they used ischemic stroke, and for the FDA's analysis, non-hemorrhagic stroke was used. Is there a material difference between those 2 definitions?
The key difference between the 2 is that the CDC definition included transient ischemic attacks as part of their definition of ischemic stroke, whereas we did not include TIA as part of our definition of non-hemorrhagic stroke.
Thank you. The second question is with regard to this study that the FDA is planning. With the signal that emerged from the VSD rapid cycle analysis, I am wondering if it would be prudent to separate the doses of flu vaccine and COVID vaccines for those over 65 years of age. And I'd just like to learn a little bit more about this study that's planned. How is the FDA going to conduct this study?
Yes, so we are planning to conduct a self-controlled analysis using risk windows and control windows after COVID-19 vaccination. We are going to specifically address the question of concomitant influenza vaccinations by looking at individuals who received either a adjuvanted or high-dose influenza vaccine on the same day that they received their COVID-19 bivalent booster. So we will have that as one of the analyses in the study to assess whether there is this interaction effect between receiving an adjuvanted or high-dose influenza vaccine at the same time as your bivalent vaccine.
I'm sorry, could I ask a follow-up question, Dr.
Of course. Yes.
Yes. So I'm still unclear about whether this study is sort of a passive analysis of whatever people receive versus obtaining informed consent for those who receive both vaccines on the same day and those that are separated.
This is going to be a study using health claims data in the Medicare system. And so while it is active surveillance, we are not going to be doing any intervention for this study.
Thank you.
Okay, thank you. Dr. Reingold?
Hi. So this goes back to something Dr. Meisner asked about a little earlier, and the concern that people who have a positive SARS-CoV-2 test might not actually have COVID-19, but have some incidental illness, but happen to have a positive test because everybody's getting tested on admission to the hospital. So while I grant that could potentially lead to an overestimate of the burden of COVID-19, am I correct that in your studies and in the studies of by CDC, Dr. Gellis and others, that if there is a misclassification of the outcome, that is, if we're including individuals who don't really have COVID, but have some other illness and just happen to have a positive test, that would lead you to underestimate the vaccine effectiveness against COVID itself?
Yes, I believe that is correct.
Thank you.
Okay. Thank you. Dr. McGinnis?
Thank you. I'm going to make a plea for consistency of language usage. So for those of us who worked in both bacterial and viral vaccines, co-administration has a different context. So co-administration can be pulling up two vaccines into the same syringe, and that is not the same as concomitant administration of vaccines. And I would make a plea for harmonization of language between the agencies. It makes it much easier to understand these already very difficult data. So thank you.
Thank you very much for that point. We will keep that in mind for future communications.
Thank you. Dr. Nelson?
Thank you, Dr. Forshee, for a fantastic presentation. I'm going to agree with Dr. Gans, who stated with the last presentation it's important to report negative findings with respect to signals. And in particular, I noted, Dr. Forshee, from your study, you identified a myopericarditis signal with Pfizer for the 18 to 35 group. My question is, and I understand the limitations of the methodology of how this data was generated, but how is that data consumed and compared with the results of other studies within the FDA? Is there a mechanism to reconcile or share cases, or are there privacy concerns that prevent the deep dive that might get at whether or not there is an important signal for this issue, which is very public with respect to concern and vaccine hesitancy in this younger age group?
Yes, we do conduct follow-up studies for any signal that is detected, beginning first with requesting medical records to evaluate the likelihood that in this case, myocarditis, pericarditis cases are associated with the vaccine. This association has been seen with the mRNA COVID-19 vaccines, with the monovalent vaccines and in other systems. So that has been considered during all of our decisions about authorizations or approvals for vaccines. We have carefully looked at the benefit risk assessment for myocarditis, pericarditis in our considerations of authorizations and approvals, and some of those studies have already been published.
Thank you.
Okay. Thank you. And I think we have no more questions, so we can move on to the next topic. Thank you, Dr. Forci.
Thank you.
The next topic is from Dr. Beigel, and who's the Associate Director for Clinical Research at the NIH, NIAID, and he's going to talk about evaluation of improved COVID-19 vaccines.
Good morning. So thank you for inviting me to talk. So this is a slightly different topic than what you've heard so far, but I was asked to talk about how we would think about evaluation of next-gen vaccines. And this slide is my disclosures. I don't plan on talking. I've got no personal financial relationships, but I think it's important to just make sure everything gets disclosed. So the prior presentations set up the need for the variants, understanding the variants over time, the emergence of new variants, what happens to that, the decisions behind the prototype vaccine. So to help frame how we are thinking about this and why we think that we need the next gen vaccines, it's helpful to understand our current strategy. So our current strategy is to use antigenically diverse vaccine strains. So in March of 2022, we started a study called the COVAL study, and I actually came to VRPAC in April, I think, to talk about our thoughts on this. But it is a study where we look at using the current available vaccines. And in this case, we worked closely with Moderna, Pfizer, and Sanofi. And we say, what are the different antigens that we could use, and how do we kind of broaden that immune response? And is there a way to use antigenically diverse strains, broaden that immune response for better protection against variants? So we started the study. It's adults only, and everybody coming in has already had their primary series. They already had a booster, could be homologous or heterologous. It includes previously infected and previously not infected or not known infected. And then they were enrolled, and they were enrolled by stage. And if you look on the right, those are the different stages. So when they came in, they were enrolled by stage and then randomized to one of these different constructs. So comparisons within a stage, I think, are valid. Because that's completely randomized. Comparisons across stage, it's a different population, it's a different time. So we try not to do comparisons across stage. So just kind of walking through the Moderna, everything is compared to prototype, but then we looked at Beta Omicron, Delta Omicron, Omicron alone, Omicron prototype. This was March, so we had the BA1 product available, not the 4 or 5. For Pfizer, same thing. I mean, we compared to wild type, but we also looked at Beta Omicron, Omicron alone, Beta alone, and same for Sanofi. They didn't have an Omicron at the time, so we looked at prototype Beta or the bivalent. We look at that data and think about things in terms of the analysis. We think about things in terms of antigenic maps. So in the VRPAC in April, I discussed the antigenic maps. Just to kind of give, I think most people on the VRPAC are familiar with, but to give a refresher, all it does, it's a visualization tool. It's not the analysis. It's not a lab test. It's just a visualization tool, but it helps you understand relative distance and of the antigens and how these are related to each other. So on that map, on the left side, D614G is this dot in blue. Any distance in any direction is a twofold dilution, and they take different populations, people that were given the mRNA 1273, people that had beta infection, people that had Omicron infection. You take different populations, you understand the immune response in that population, and then you start triangulating this, and then you get some understanding of how these different antigens are related to each other. all that shows is relative distance. It doesn't tell you absolute values of anything. So on top of that map, we use antibody landscapes, and that's what's on the right, where you actually start seeing titers, and you start seeing titers and how they vary across that map. So you take that map, just kind of flatten it out. The D614G is this peak here. The Omicron is this red dot here. That map just flattened out. And this is an example of the mRNA 1273 sera. And you see the peak over the D614G, and then this slope drifting down lower and lower titers as you get towards these antigenically more contemporaneous strains like Omicron BA1. So this is the COVAL data. So first, let me just go through the setup. This is the Moderna set. So all those arms that we talked about, this is day one at the bottom. This is day 614G. This is the map, trying to just simplify to the dots. BA1, BA4, 5 is here. So what you see is not unexpected at baseline, again, after 2 vaccines and then a booster at baseline. They've got moderate titers, but then they drift down considerably as you get towards BA1, BA4, 5. Post-boost, and this is 91 days post-boost, we increase that, everything, regardless of whether it's prototype or any of the variants we use, you increase those titers, you increase that across that antigenic space, you flatten that out. So regardless of what we use, we accomplish that. This red slope here is prototype. Everything else, those other 4 arms, are all right on top of each other. And so what you start seeing is, yes, they all work. Prototype increases titers across that map, but anything besides prototype does it slightly better. And this is Delta, Omicron, prototype, Omicron alone. They all really look remarkably similar, but different than prototype. Pfizer, it's a really similar story. You see, again, the day 1 at the bottom, the day 91 at the top. Everything, regardless of what we use, increases that curve, increases that antibody response across those different variants. But everything is better than prototype alone. And even things that didn't contain Omicron are better to Omicron, like beta. I mean, beta is at the top here. Beta is this yellow near the top. So that increases, that new antigen increases response to Omicron. This is Sanofi. I mean, again, a really similar story. The day 1, the day 91, you flatten it, you increase the titers, you flatten it across that antigenic space, but beta and prototype beta better than prototype alone. It's important. The last point is that bivalent vaccines perform similar. Beta alone, you don't need the prototype. Beta alone performs similar to monovalent vaccines. This is a smaller data set. This is done in a different lab because it can get more contemporaneous strains quicker. So this is one of the arms from Moderna, the Moderna Omicron BA1 and prototype arm. And what I want to point out here is just how fast how well we keep up with newly emerging variants. So we started the study in March, April, this part of the study in March, April. BA1 titers, good. I mean, you see where we're at, come in, titers around 100. We boosted titers well over several thousand and kind of drift down by day 91. But as we get more antigenically contemporaneous, and you see the BA4-5 here, you don't get that same response. You see the BQ1 and the XBB here. Here, I don't have a day 0, but peaks. I mean, peak response to XBB is right around 100, and that's that blue dotted line. So variants that emerge within 9 months, our titers are relatively low to those new variants. And why did I highlight that line of 100? Well, I think there's data to suggest correlates of protection analysis. That efficacy decreases as lower neutralizing antibody titers. And this is a paper from Gilbert, but you just see this consistent message of correlation of protection, decreasing titers. And once you get down to 100, you start seeing that efficacy get below 90. I want to highlight that the antibodies are good, the vaccines are good against severe disease and actually are the best against severe disease. There is data about asymptomatic disease, and there's cohort studies that suggest protection for asymptomatic disease, and I highlighted one. There's several of these, but it does work for asymptomatic disease, but the efficacy against asymptomatic disease is lower than symptomatic disease. And at the bottom, if you look at VE for severe hospitalization, severe COVID cases, symptomatic COVID or asymptomatic, you move from a VE of 97 to 93 to 63. So the current vaccines are really good for severe, okay, or good for symptomatic, but as you start getting asymptomatic disease, VE gets down towards the 60s. What do we know about transmission? A slightly different concept. Again, there are cohort studies that suggest protection against transmission and their protection within a household. And if a person is infected, you get similar peak titers and maybe slightly less duration of shedding. That might decrease the transmission some, but a complete protection against transmission is lacking. I'll be the first to admit, definitive studies evaluating transmissibility are lacking. There are small data sets, but the data suggest some transmission, some protection against transmission, but it's modest at best. So just to reiterate, the current vaccines remain effective against COVID-19. The efficacy against severe disease, and that's obviously the most important outcome. Symptomatic disease is a little less, and asymptomatic disease and transmission seems less than that. We've shown high titers aren't sustained over long periods of time, and those the cross-reactive antibodies to new variants that emerge within a year are marginal, i.e., we weren't successful in flattening that landscape that I showed you, that antibody landscape. We weren't successful in flattening it enough to cover newly emerging variants with high titers. So that brings us to why we think, we need next generation SARS-CoV-2 vaccines. And when we think about it, the key properties are one or more of these: enhanced breadth of protection. And this concept of variant proof, and I think different groups define that differently: improved durability or enhanced ability to block infection and transmission. And how would you go about that? I think there's a number of groups working on this. There's new antigen constructs to generate broader immune response. Some are going after conserved elements, some are going after more of a mosaic approach. They give different, more durable immune response. And then there are groups targeting mucosal immunity and intranasal or oral administration to generate a mucosal immune response. And then some groups doing a parenteral administration, but with something that will give you more mucosal immunity. So how do we advance this field? So for Operation Warp Speed, there was good data to support which vaccines to advance. There was decades of preclinical work supporting the antibody role in minimizing severe disease. There was work with the mRNA vaccine platforms and the other platforms. So we knew which ones to advance. For next gen vaccines, especially mucosal, I'm going to argue that more data is needed. Which vaccines are likely to increase the breadth and protection and durability is not clear. How do you define the vaccines, or how do you pick the vaccines that will limit asymptomatic transmission, asymptomatic infection and transmission, and what are the immune correlates associated with that protection of asymptomatic infection and transmission? we know it's not all antibody. So this is an analysis, again, from Peter Gilbert that showed how much of the VE can be attributed to antibody titers, and in the analysis they call that indirect VE, and how much is through other mechanisms, other pathways, and that's direct VE. And then that proportion is on the far right side, and that proportion in this paper, and this is the Moderna paper, suggested 68% of VE is attributed to antibody. But then I bring in this table that I've already showed you about different VEs for protection against severe or symptomatic or asymptomatic, and the role of neutralizing antibody that I just said that 68% mediated is likely not true and is not going to be equal across these different outcomes. And how do we start understanding what protects us against severe, what protects us against asymptomatic, et cetera. So in addition to neutralizing antibodies, what mediators might be contributing, this is a paper that we've done, that we published a year ago, that was, we call it the mix and match study. But it is looking at different primary series, different boost. So this is people coming in with the Ad26, the mRNA 1273, or the Pfizer, and boosted with different things, boosted with mRNA, boosted with Ad26, et cetera. This is the cell-mediated immunity from that. And you see that there are differences. I mean, the mRNA, both Pfizer and Moderna had a very different CD4 response than the Ad26. But the Ad26 has a very different CD8 response. So coming back to that prior, if we know antibodies aren't everything and we know cell-mediated immunities might be a role here, and how do we start differentiating cell-mediated immunity for severe versus asymptomatic disease? So there are analysis ongoing for this. I mean, from our COVAL trial, we're working with Peter Gilbert again on that. And they're looking at neutralizing antibodies and T-cell analysis, and we've got T-cells on about 70% of that group. So that analysis is ongoing. Some companies are their pivotal studies also had some cells, and Janssen, the COV 2008 study has some cell-mediated immunity, and there's probably other groups that didn't mention. But the point that there are groups working on cell-mediated immunity. But there might be other things. We know nasal IgA titers are related to protection. This is a paper that just showed nasal IgA or IgG. IgA is that darker blue, and the IgG is the lighter blue. And the risk of Omicron breakthrough related to those, and the higher the IgA, the better, and that's what this analysis shows. But that's baseline IgA titers. That doesn't tell me how I modify that. That doesn't tell me if a vaccine changes that. That doesn't tell me if the changes that I measure are actually going to be related to differences in vaccine efficacy, especially those outcomes of transmission and asymptomatic infection that we are increasingly interested about. So, it's really hard to kind of clarify what to measure for mucosal. I don't know what happened there. What to measure for mucosal vaccines. The contributions from systemic or mucosal, the mucosal antibodies, is that what I'm interested in, or a mucosal cell resident immune response? Do I look in the nose or the mouth, the nasal or salivary, IgA or IgG? And if I'm looking at cells, or I think CD4 or CD8, and you start seeing the complexity and the gaps where we need a lot more information to really understand what to measure for mucosal vaccines. So coming back to kind of frame the question that I was asked, I mean, how do you evaluate next generation COVID vaccines? So the evaluation of current generation COVID vaccines, either efficacy trial for prevention of symptomatic disease, and or non-inferior immunogenicity. I think there have been attempts to try to outline what that would look like. So the evaluation of the next-gen vaccine, I think, starts at the same place. Either pivotal trials for efficacy, non-inferior immunogenicity, and there's going to be some vaccines that just come in and say, we've got better breadth, we've got better durability, and that will be a huge improvement for us to get there. But then there's going to be others to really say, in addition to those, how do we measure outcomes that we're now interested in? And that includes asymptomatic disease, that includes transmission. And to really get there, to advance those vaccines with these additional outcomes, we need to understand and identify the immune markers related to the outcomes of interest, think about and try to analyze the immune response necessary to impact transmission or asymptomatic infection, evaluate the correlates of production using those parameters. So again, just because an immune marker is there doesn't tell me if it is correlated with parameters, with protection, standardize sampling techniques, and develop optimized and validated assays. And I think all these right now are lacking in this field. So to wrap it up, I try to make a case that there's a public health need for next generation vaccines. Some next generation vaccines will be advanced using data and assays similar to the pivotal trials of our current vaccines. That broader protection against emerging variants, and we can discuss what that looks like, increased durability. But we also need to understand the immune responses that are protecting against infection and asymptomatic infection, transmission. And these are the outcomes that are increasingly important to us because we've accomplished that first task of preventing the severe outcomes, minimizing the symptomatic disease. Now let's talk about how we get to this next step. And I think together, this set of data will let us identify the most promising vaccine candidates to further decrease COVID-19 disease. So with that, I'll stop and we'll take questions.
Thanks, Dr. Beigel, for an excellent presentation. We have 5 minutes for questions. So, Dr. Gans.
Thank you so much. I mean, it was a beautiful presentation. I think you really outlined some of the challenges that many of us on this committee have been really also speaking about for quite some time, particularly the correlates of immunity. And you outlined them beautifully. I mean, my concern is time, and we're always at this point of having to make decisions without that data that you suggest. So I just wanted to really applaud the conversation now. I mean, but to push people to really look at these markers. I did have a question about the data that you actually presented and that then tipped you into this. Of course, we need vaccines that look at different mechanisms. And that was that I think the data that you presented actually didn't include any of the current bivalents with the B4, B5, if I'm correct in looking at that. It went by very quickly and really only had the B1. And we know, again, according to your graph, that there actually is more characteristics that are related to the B4, 5. So anyway, I just wanted to say that there could have been some better variant control.
Without a doubt. And just to bring it back, at the very bottom, and I didn't highlight it, we started in March, and at the time we had the BA1. So that was how we constructed the trial. We did add a stage 4, which is wild type BA1 versus wild type BA4, 5. We're just starting to get that data, and the N that we had was really small. So we chose actually not to present that because I think that's way too speculative at this juncture.
Okay, thank you, Dr. Levy.
Thank you, Dr. Beigel, for excellent presentation. Really a critical topic I've brought up at many of these meetings, as you may know. The desire of myself and I know other committee members to have a better sense of how these vaccines are protecting. We need to learn as a community how to keep doing it better. The enormous success and progress, and yet a long way to go, as you highlight. Regarding the antibodies, as we know, these are all correlations we're measuring. We don't really prove the mechanism of vaccine efficacy. And there could be deeper ways, of course, to measure the antibody, system serology and other approaches that give deeper insight into the exact types of antibody that are being induced. The T cells, you mentioned CD4, CD8. We don't talk a lot here about innate immunity. Not that that's probably the main mechanism, but there could be aspects. It's already been shown that mRNA vaccines can reprogram innate immunity and change innate immune parameters in humans, and maybe those contribute to early protection, possibly. And then, of course, how do these correlates of protection play out in different populations? They might not be identical, their contribution in very young infants versus older adults versus those with comorbidities versus immunocompromised. Systems biology can be a tool to cast a broad net, without any bias as to which mechanisms may most contribute, but it's costly. And how do you nest that into the clinical studies? So, you raise a whole range of very, very important concepts and principles. And I hope FDA will continue to reflect on how to best take this information forward and encourage or require sponsors to gather more information in a standardized way across these different arms of the human immune system. So we keep learning and keep doing this better. And I look forward to continuing that conversation. We'll also be in touch offline. Thank you.
Thank you. Dr. Rubin.
Thanks, Dr. Weigel. I'll join everyone else in thanking you. I guess the question is, if you induce immunity using a completely different mechanism, do you expect that the correlates of immunity are going to be the same?
I mean, you're absolutely right. The answer is no. I mean, that was what you were implying, but you're absolutely right with that suggestion. I think if you're inducing a different mechanism like a mucosal, you really have to do the evaluation to say what is the breakthrough and start getting that information of what the correlates are, because we can measure things, but I don't know what they're going to mean, right? We're going to measure IgA, but I'm not sure what that, and the mucosa, but I don't know what that necessarily means until you start doing correlates of protection analysis. And there's no reason to believe that the correlates of protection across the different platforms will be the same. You're absolutely right.
Okay, thank you. Dr. Hildreth, a brief question.
Thank you, Dr. Perlman. And thank you, Dr. Weigel. I have a question about convergent evolution. More than 9 million viruses have been sequenced, and it's very clear that there's a convergent evolution happening, especially in the receptor binding domain of the spike protein. Are any of the vaccine approaches you're taking into consideration this, which might help us a lot if we could somehow factor that into our design of vaccines?
Yeah, I mean, it's an interesting question. I don't think we're to a point where we can actually predict the vaccines very well. All right, we are to a point where we know what that antigenic map looks like and how the different variants are there. We can get to a point where and groups are working on this, where you see genetic mutations and you start modeling and assessing the viral fitness. And so you kind of start nibbling around the edge of that map that we have. But I don't know what that entire map is. And until we're to a point where we can say, this is where we're at and this is the direction we're going, and we're not there. I mean, it would be great if we're there. We're just not there with the science.
Thank you so much.
Okay, thank you. So we have time now for a 9-minute break, coming back at 11:30 Eastern time, because we have a tight schedule until the public hearing at 1:30. So 9 minutes, and we'll see everybody back here.